Good morning, everybody, or good late morning here on the East Coast. We'll just give everybody a minute to get into the room before we start. Good morning, Dr. Lonsberry. How are you?
I'm good. And you?
I'm good. I know it's morning for you. I know it's
Yes, it is.
early for you. We're here on the East Coast getting ready for lunch. So it's a rainy day here, so it's a perfect day to spend on our
Yeah, it's
second
it's
day.
not very nice here. I'm in Oregon, but it's a little overcast today. So yeah, it's fine to be inside.
Perfect. It's a perfect day for all of us to get some CE credit. So, well, I will get started with. We know we have a lot of information to cover. So, good morning and welcome to Wu University. This is our second day of our oral pharma weekend. So, we have another 4 hours today. So, we hope that you joined us yesterday. If welcome, you're in for a great treat today. So, the first presentation of our day is Simplifying Systemic Antibiotics with Dr. Blair Lonsberry. I'm your host, Dr. Jennifer Stewart. And it is my great pleasure to introduce Dr. Lonsberry. He grew up in Rossburn, Manitoba, Canada. He obtained his optometry degree from the University of Waterloo in 1996 after completing a Master of Science in Physiology from the University of Manitoba. He completed his residency in primary care optometry from the Illinois College of Optometry in 1997 and joined the faculty at Southern College of Optometry in Memphis. During his time at SCO, he completed a master's in education degree with an emphasis in adult learning. Currently, he's a full professor with Pacific University College of Optometry in Oregon, where his primary teaching responsibilities are supervising interns and overseeing a specialty lumps and bumps clinic. In his spare time, he goes to Anchorage, Alaska, where he sees patients in a private practice, and he has two white German Shepherd dogs named Bo and Bennett who keep him sane-ish, which we got to see pictures of. And we spent the morning talking about that. He's a diplomate of the American Board of Optometry, a fellow of the American Academy of Optometry, the Optometric Retinal Society, and the Optometric Glaucoma Society. Welcome to University, Dr. Lonsberry. We're super excited to have you, and I'm going to turn it over to you.
Thank you very much. Good morning, everyone, or late afternoon or late morning for some of you on the East Coast. It's a pleasure to be here. We are, I do speak for these various companies, and we are going to be interactive this morning. So if you wouldn't mind, I want you to log into my Poll Everywhere. So probably the easiest is just kind of pull up your cell phone and use the QR code. Or if you want to type in the address into another device, you can do pollev.com, then / Blair Lonsberry with no spaces. We are going to have some cases as well as some other questions. So it would be nice if you could engage with me and your colleagues. So if you wouldn't mind logging in. I know Nate will be doing his the same way in the next lecture as well. So it'd be nice if you could log in for me. You don't have to. It's not going to register you. We're not doing attendance this way, but hopefully I'll have a few of you log in so that we can have some discussion. I'll give you a second more to do that. All right. So here's your first question. So taking a look at this condition, what's the most likely causative agent for this condition pictured? So a lot of times when we see things like this, we don't necessarily do culturing on it. We kind of know empirically what bugs tend to be there. So if you saw this condition, what's the most likely bug that's causing this? And again, if you want to log in, you can just use the QR code up there to the right. All right, let's see what you said. So the majority chose staph, and we know that majority of the bugs on the lids tend to be gram-positive, and staph tends to be the most often that's there. If this was a kid, then I think potentially more into the strep or Haemophilus group. Pseudomonas is a particularly scary bug. If you look at the World Health Organization's top 10 scariest bugs, Pseudomonas is on that list. Why? Because it's gram negative, which makes it kind of very difficult to treat. And it's also really present in everything. We know that Pseudomonas can go through, any abraded cornea can go through that cornea in about 24 hours. So it's one that we do get particularly worried about. So with this lecture, what I want to do is kind of really emphasize the systemic use of antibiotics. I think when it comes to topicals, we do topicals really well. We don't tend to kind of think twice about topicals, but when it comes to oral medications, I think we sometimes tend to hesitate and tend to, have to think twice about what we're going to prescribe. There are certain conditions that we're definitely going to need to prescribe an oral medication for. So I want to just make you feel a little bit more comfortable about prescribing those medications. In addition to that, we are going to see that I'm going to be treating similar conditions with different antibiotics. And that's important because we know that patients might be allergic to a medication or there might be a cost issue. So you'll see that I'm treating similar conditions with different antibiotics, just again, to give you more options. So when we're doing antimicrobial therapy, what we're trying to do is find something that's different structurally with the bacteria versus our human cells. So we don't want to be giving a medication that's potentially toxic to us, but we need to get it into that bacteria and kill it. So when we talk about what's called a therapeutic index, a therapeutic index is the difference between where you get toxicity and where you get your therapeutic benefit. And what you want to see is a really large therapeutic index. In other words, that range where it's therapeutically effective is very different when you get into toxic doses. And that's, becomes important for medications, say like warfarin. Warfarin, which is a blood thinner, its therapeutic index and its kind of lethal dose or toxicity is actually very, very close. So they have to be fine-tuned in there. What we want is a larger therapeutic index where we're not potentially causing, damage to the human cells. Any medication given in enough strength or concentration can be toxic, but what we're trying to do is really find something about the bacterial cells that are different than human cells. For example, your penicillins, they work on the bacterial cell wall, while humans don't have cell walls. So for us, they're really pretty non-toxic. The other ones, the ribosomal subunits, they're different in bacteria. So if we can target that, then it's going to be different than our human cells. So when we choose an antimicrobial agent, we have to have some things that we need to consider for who we're prescribing it to. First one's the knowledge of the organism's identity. And again, when I showed you that picture before of the sty, that we know that the likelihood is it's going to be staph. What we tend to do culturing for is if we really have no idea, or you're treating it and it's not getting any better. We also need to know its susceptibility, which is why we get worried about resistance issues. The site of infection, patient factors such as blood pressure, kidney issues, that type of stuff. And then the cost of therapy needs to go in there as well. When we start talking some newer antibiotics, I just wrote an article recently on the whole FDA process and getting it approved, medications approved. And on average, it takes about 8 years to take a product from kind of compound to the market, and it costs anywhere from $800 million to $2 billion for them to get it approved. So that's why we see brand name products being pretty expensive, because they have to try to recoup their costs. And unfortunately, when it comes to antibiotics, they're not potentially going to make that money back because we're not necessarily going to prescribe them all the time. So pharmaceutical companies are not really investing a ton of money into antimicrobial research because they really can't recoup their costs. And so the downside to that is that we don't really have any new antibiotics coming out. And that's becoming a challenge because of resistance issues and what we're going to do for newer infections if we don't have anything that's coming in the pipeline. When we start talking about prescribing, children 12 years and older can be dosed as adult, unless special considerations such as, size. It might be that someone who's 12 is particularly small, so you don't want to maybe take body size into consideration, but typically 12 and above are dosed as adults. So we have two modes of action with antimicrobial agents. One's what's called bacteriostatic agents, and these drugs basically shut down the replication process of the bacteria. It doesn't necessarily kill the ones that are already in the system. It just arrests their ability to reproduce. And at that point, we're relying on the body's immune system to take care of the rest of that infection. Whereas if you have bactericidal agents, they kill everything in the system. So at concentration, serum concentration levels, they'll kill all the bacteria that are there. So why don't we not just use bactericidal agents all the time? Because they tend to be indiscriminate killers. So in other words, they tend to kill not necessarily that bug that they're kind of what you want to get rid of, but potentially other bugs as well. So there's much more chance for toxicity issues when you're using bacteriostatic agents. With bacteriostatic agents, you're going to want to be careful that the patient has an intact immune system. So you may not want to use that medication if the patient is going through chemotherapy or has an immune compromised system, like having more advanced AIDS. So we need to get adequate levels of the antimicrobial agent to the tissue that's infected. When it comes to ocular tissue, particularly the ocular surface, we know that topical drops are going to get that highest concentration that's there. However, if we're dealing with the skin, really at that point, topical medications aren't going to be all that effective because we need to penetrate that barrier, get it inside the tissue. So for treating things like preseptal cellulitis, even internal hordeola, we're going to need to go the oral route. We're going to need to do a systemic administration because we need to get adequate levels to that tissue. So again, patient factors that we want to consider are kidney, liver, and circulation. Your liver is your primarily area where you're going to detox stuff. So when you swallow a pill, we have to think about what happens. When you swallow a pill, it obviously gets into your gut, tends to get broken down by the gut or the intestines. Then it gets absorbed at that area. Then it goes through what's called the hepatic portal system. And the hepatic portal system takes that blood from the gut and sends it to the liver. Then it gets what's called first pass clearance through the liver. Then it gets into the circulation. So pharmaceutical companies spend literally millions of dollars trying to figure out that process and making sure that there's adequate levels getting into the circulation in order to get to the tissues. And so that's why, certain medications may be enteric coated, which means they have a clear coat on them. And that enteric coated means that it's not going to be broken down on the gut because it may be destroyed by the gut juices that are there and more designed to be absorbed in the intestines. There's 1,000-fold increased chance for absorption in the intestines than there is the gut. So a lot of medications are actually designed to be absorbed in the intestines so that ultimately we get a greater amount of drug into the system. Most elimination of drugs is via the kidney. So if you have poor kidney function, then it can also increase the chance of toxicity because you're just not getting rid of that drug out of the system. So many antibiotics are minimally toxic. That would be like your penicillin group. Because they act on the cell wall and we don't have cell walls, then for us, they're really pretty gentle to us. Others are kind of reserved for more life-threatening infections. Good example, that's chloramphenicol. Chloramphenicol is an amazing antibiotic. It kills everything, including the patient. There's such a good chance for potential toxicities like aplastic anemia with that one, that it's pretty much left for more life-threatening conditions. Spectra, we have narrow spectrum antibiotics. So something like isoniazid, which is only used for tuberculosis. That's the only real indication for it. It's pretty narrow spectrum because it's only used for that one condition. We have extended spectrum antibiotics that do both gram-positive and gram-negative. Then we have broad spectrum antibiotics, which basically is effective in killing a wide variety of different microbia. And so again, why don't we use broad spectrum just to make sure we're kind of blanking into the system? And that's because it can drastically alter our normal flora. And you have to remember that we have a microbiome, particularly in our GI system, that's there to help, break down food, to carry stuff. And if you change that flora, then you end up changing how your body's working. So here's our next question. Which of the following would prompt you to consider treating the patient for a possible MRSA infection? So you're seeing a patient and you're potentially suspecting MRSA. Which of these would trigger that thought? Right, I'll give you a couple of seconds more. All right, and let's see what you said. And the correct answer is really all of them. So if you have a person that's, if you are actually already treated with Augmentin or amoxicillin and it didn't work, then I potentially suspect MRSA. Pain outside the clinical presentation. So if you see someone that looks like they have potentially a sty or a hordeolum, but they're saying the pain's 10 out of 10, then I would again consider it potentially to be MRSA. If a patient's ever had a history of previous MRSA infections, then that always has to come to the top of your list. If patients had MRSA, then they pretty much always have MRSA. Healthcare workers, any history of recent incarceration or hospitalization, and then well, pretty much all of those, right? So really anybody who, and the other one would be that it doesn't actually present in the location you would expect it to be. So if you're expecting it to be a hordeolum, you're expecting it to be on the lid part, but say it's up here more towards the brow, then that again would be an indication that maybe this may be MRSA, not just a normal infection that you're thinking about. So what we get worried about is, yes, I want you to use systemic antibiotics, but we have to also make sure that we're not increasing the chance for resistance. Because there's not a lot of new groups of medications coming out, we need to make sure that we're treating and not developing resistance with those antibiotics. And resistance happens pretty much in 3 different ways. They either produce an enzyme capable of inactivating that antibiotic. There's always receptor sites on cells to allow antibiotic to get into the cell. Well, they either change that receptor site, which doesn't allow the antibiotic to bind, or when it does and puts it in the system, they turn around and pump it right back out. So bacteria are actually really pretty smart on how to figure this stuff out. And interestingly, they will not only share that information with their own species, but they'll actually do it cross species wise. They'll basically send out this little package of information and said, here, this is how you get over this antibiotic. So that's why you have to be really kind of careful about treating, in particular, non-bacterial infections, so viral infections with an antibiotic, because effectively what you're doing is giving a chance for the bacteria that are there to figure that out. So how do we kind of prevent that? Thankfully for us in the eye care world, particularly when we're treating topical infections, we so overflood or overwhelm the system that we really don't have a high chance of developing resistance. But ways that you want to make sure that that doesn't happen is to make sure that you avoid prescribing for any non-bacterial infections. So the majority of red eyes that come into your practice on an emergent basis are likely actually going to be viral infections. So again, not treating it with an antibiotic. Avoid sublethal doses, in other words, attack to kill all. Don't kind of be in that borderline area where you're figuring, well, I don't want to do higher doses because, chance for resistance. That's actually going to help reduce resistance because you're basically killing all the bugs that are there. Avoid intermittent use, always complete the full dosage, and then never taper an antibiotic. So the tapering of the antibiotic would be, so if we're doing topical drops, you can say be treating a corneal ulcer and you're doing it every 15 minutes for, a couple hours, and that's every hour after that. Then you start kind of weaning it down, and that is a taper, but you don't want to bring it down below the minimum level that antibiotic's prescribed for. So if it's say twice a day, they'll never drop it down to once a day, because that's really what your taper is. That's a chance for the bacteria to figure it out. The one that we tend to probably taper that we shouldn't is Tobradex. We tend to think about the fact that there's a steroid there, and there is, but Tobradex shouldn't be used long enough in order for you to need to taper it. And if you do need to taper it, then I would recommend that you take them off the Tobradex and put them on a separate steroid so that you're not, again, tapering that antibiotic. So the Infectious Disease Society of America came out a few years ago and said that for adults, the length of prescription should be no more than 5 to 7 days. So if you're treating an adult and you haven't taken care of that infection in 7 days, then that antibiotic's not going to take care of it. So you need to switch them to something else. Don't renew that prescription. In other words, if you're using Augmentin, you've done it for 7 days, hasn't resolved, then don't give it another prescription for Augmentin. Switch them to something else like Keflex or Ciclor. Kids in that 10 to 14 day range, but I've read articles recently thinking that for kids, that should be probably in the same time period for that 7 days. If you haven't taken care of that infection in 7 days, then switch them to something else. So again, MRSA, there's 2 types. There's the healthcare associated MRSA. This is more associated with people who are hospitalized, kind of incarcerated. And this is what we tend to think the majority of patients are getting MRSA is from these facilities, but that's not really the case anymore. The community-associated MRSA is definitely on the rise. And we are seeing patients coming in who have not been incarcerated, have not been in a long-term living facility that are developing MRSA. So we have to be kind of really aware of that. In particular, if we're treating an infection and it doesn't seem to be getting better in the next couple days, then we need to consider that MRSA is a possibility for them. Again, those kind of considerations where you might want to put MRSA at the top of your list are those different situations, right? So there's a history of non-response to amoxicillin or Augmentin, history of previous MRSA infections, say an infection did not start on the lid margin, like a regular hordeolum, but it's up closer to where the eyebrow area is, history of recent incarceration or hospitalization, any healthcare worker I would kind of put on that list as well, and then pain outside the clinical presentation. So this picture to the right is actually of my roommate who had taken our 2 dogs out for kind of a walk and came back and said, I think I got bit by a spider. And that's actually a common comment for people who end up having MRSA infections, that they think they've got a bug bite. And we don't really have any biting spiders here in Oregon. And so he had got this bump in the back of his neck, went to his doctor, and they started him on Augmentin, wasn't getting much better. So they decided to kind of cut it open, and they actually left the wound open so it would drain. They cultured it, and it was actually a MRSA infection. And what they thought was that because he was out hot and sweaty, he got a pimple and developed into kind of like a super pimple and developed a MRSA infection. So at that point, he pretty much has MRSA for the rest of his life. So again, he wasn't in a hospital situation, wasn't incarcerated. So we have to be kind of aware that MRSA is out there and potentially might be presenting in our patients. The ARMOR data, this is the antibiotic resistance for ocular bugs. And what they do is they take samples of anybody who has a keratitis or conjunctivitis. They collect those samples, send them to a lab, and they analyze what bugs were in there. The last results showed that about 40% of people who had either an infectious keratitis or conjunctivitis was actually MRSA. So you're talking probably more than a third of the time, if you're truly treating a bacterial keratitis or conjunctivitis, that you have to consider that MRSA is a possibility. The newer fluoroquinolones have better activity than the earlier generations. So, your 4th gens are going to work better than your 3rd gens. There is increased resistance to tobramycin. And Besavance has the lowest MIC values of all the fluoroquinolones, which means it has the best kill rate. Also has an indication for MRSA and Pseudomonas. Vancomycins are a drug of choice. If you really do think that there's a MRSA infection in place, I'd probably start them on Besavance until you can get vancomycin compounded. It has to be compounded. At that point, you might want to make sure you know where there's a compounding pharmacy, but it may not just be readily available. It has to be compounded up for you. And sadly, azithromycin, which is a very commonly used oral medication, has pretty poor activity against staph. All right, so we're going to start talking about the different groups now. The ones that I'm going to spend the majority of my time on are the inhibitors of the cell wall synthesis. These are your penicillin groups. I have a lumps and bumps clinic that I do Tuesday afternoons. The majority of what I have come in are chalazions, which I tend to inject, but I also have an Elman unit and I do small procedures. So I spend a lot of time doing oral antibiotics for people who are coming in with hordeola and other lid infections. So for me, this is a really important group of medications. Again, they affect the cell walls, and bacteria have cell walls, but human cells don't. So they're acting on something very specific for the bacteria that are really pretty gentle to us because they're not really affecting any of our normal processes. They do inhibit that bacteria's ability to form a cell wall. So at that point, they can't maintain structural integrity because they don't have that cell wall in place. The big group in this one is the beta-lactam antibiotics, and that's what we'll spend most of our time talking about. But vancomycin is also in this group as well. So in the beta-lactam antibiotics, the important part of this group of antibiotics is what's called the beta-lactam ring. The beta-lactam ring is kind of this little offshoot from the molecule, and it's the active component to it. Well, staph has gotten really smart. It produces penicillinase, which actually cleaves off the beta-lactam ring and inactivates the antibiotic. So what we have to do is keep that molecule intact. And that's where the difference between amoxicillin and Augmentin is it's still amoxicillin as the antibiotic, but Augmentin's got clavinic acid or clavionate added to it, which is an enzyme that inhibits that penicillinase from cleaving off the beta-lactam ring. All the penicillins have relatively short half-lives. And then those beta-lactamase inhibitors are sometimes added to that antibiotic to make sure that we are getting over enzymes that bacteria have produced in order to inactivate the antibiotic. These are among the most widely effective and least toxic of the medications, again, because they're working on the bacterial cell wall. However, because they've been around for so long and used so readily, resistance is becoming a big issue. What we've seen in the last few years is not necessarily new groups of antibiotics coming out, but new additions to them, like beta-lactamase inhibitors, to prevent the resistance that's being developed by shutting down the enzymes that the bacteria are producing. The most common side effects include hypersensitivity and diarrhea. So antibiotic-associated diarrhea, remember we talked about, the microbiome in our guts. It's really important for maintaining just our normal, body functions. So, going to the bathroom, et cetera. And when you change that, you increase the chance that patients will develop diarrhea. Amoxicillin is among probably the biggest ones that will do that. And so this is because it's disrupting that microbiome. Amoxicillin is high on that list. So we need to make sure that we're trying to mediate or minimize that effect. And we want to recommend a probiotic, typically about 2 hours after they've taken amoxicillin or Augmentin, that you recommend that they eat a container of yogurt or some form of other probiotic to start replenishing that normal microbiome that's there. With amoxicillin, you definitely want to be taking it with food to start with, but then you want that probiotic about 2 hours after. You don't want it at the same time because, again, it's going to shut down the antimicrobial agent. It's going to start killing any useful bacteria that are there. So 2 hours after eating a container of yogurt or some form of other probiotic is going to really help stabilize your patient's gut. Patients really do appreciate that if you tell them this. Just remember, 2 hours after eating a container of yogurt or some form of probiotic. So what percent of the population has a true penicillin allergy? So what percent of the population has a true penicillin allergy? All right, let's see what you said. And the correct answer is actually 1%. Now, I would think if you ask the population who has a penicillin allergy, it's probably one way over here, the 1,000,000%. In reality, 10% of the population believes they have a penicillin allergy. In actual reality, 1% of the population does. So the CDC came out a couple of years ago and said that if any patient comes in, any healthcare professional, and they end up stating they have a penicillin allergy, that you recommend that they get penicillin testing done, because we're taking out a major group of antibiotics that is really useful, particularly for skin infections, from potential prescribing. So recommending they get penicillin testing done. Patients could have actually had a penicillin allergy when they were a kid, but after 10 years, 80% of those patients will actually lose that allergy to the penicillins. I wrote an article recently on this, and the recommendation from the article was, patients, look at the difference between side effects versus being allergic. So patients got nausea, diarrhea, that's a side effect. That's not being allergic to it. True anaphylaxis is you're getting the hives and the breathing issues. If patients had a history of an anaphylaxis, in other words, they had breathing issues or hives, then to recommend they get penicillin testing done. If there was no history of an anaphylactic response, then they recommend doing a direct challenge. And the direct challenge means that you're actually going to prescribe that antibiotic to that person and see what happens. Well, most people, if they believe they have an allergy to penicillins, are not really going to like that direct challenge. So I recommend they get penicillin testing done. They can do that through their primary care physician. And to me, it's just really important that we actually figure out whether they have a true penicillin allergy or whether or not we can start using that group of antibiotics again. Because ultimately, penicillins are very closely related to cephalosporins, which is the next big group. And we tend to not want to prescribe for patients who have penicillin allergies the cephalosporins. So it's taking out a major group of antibiotics. And so my recommendation to you is if you have someone comes in who said they have a penicillin allergy, is that to recommend that they get penicillin testing done. So amoxicillin is our first one, 250, 500, or 875. There is an extended release formulation of 775. don't tend to see that used all that often. It's pretty pricey. So most people do, $8.75 twice a day. Here's some of the other penicillins that are out there, not something that you're likely going to prescribe, but penicillin G and V are used for all stages of syphilis. Ampicillin is used more for as prophylactic treatment for patients who are having dental surgery. And then nafcillin, an IM or IV preparation, again, for more kind of like septicemia, endocarditis, again, something that you're not likely prescribing for. Augmentin, this is pretty much my go-to for anybody who has a lid infection, so a preseptal, internal hordeola. Internal hordeola are actually classified as a low-grade preseptal. So if I have someone who has an internal hordeolum, I'm actually likely to offer them up an oral antibiotic than just doing warm compresses and massage. With Augmentin, you've got the addition of the clavinic acid to it. Clavulin, if anyone happens to be from Canada, that's your equivalent to our Augmentin here in the States. That clavinic acid is 125 milligrams, and it's consistent in all the different doses. So it's 250, 125, 500, 125, and 875, 125. Remember that the clavinic acid is just an enzyme. It has no antimicrobial properties. So that means that 250s is not equivalent to 500 because you're doubling up on that clavinic acid. Good for really any soft tissue infections. So things like dacryocystitis, internal hordeola, preseptal cellulitis. For kids who get inner infections, it used to be amoxicillin was the go-to. Now it's Augmentin. Same thing for if you're confirming it's a true bacterial sinusitis. Again, the standard used to be amoxicillin. Now it's Augmentin. So kind of reactions to it. It does have low GI upset. I don't know if I necessarily agree with that. I do think it will potentially result in people having, some GI nausea, diarrhea, which is why we want to recommend they use probiotics. Allergic reactions and anaphylaxis is our biggest concern for any orally prescribed medication, more kind of in the line of anything that has got a sulfa base to it. But anytime you prescribe an oral medication, you always want to educate them about the signs and symptoms of anaphylaxis. So if they start developing hives, any breathing issues, then they need to stop that medication right away. What we don't want to develop is Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a rare, serious disorder of the skin and mucous membranes. It's a massive inflammatory response secondary to typically oral medications, and it can be life-threatening. It starts to cause blistering of all the mucous membranes. It can start affecting the lungs as well. So really educating anybody you prescribe an oral medication to that if they notice any blisters showing up in their skin, any breathing issues, that they need to stop the medication instantly. That's very different than, so people who are allergic to medications, those symptoms tend to show up pretty rapidly. Side effects usually take a couple of days to develop. So if someone starts taking, say, Augmentin, they're not going to have the diarrhea, GI upset that first day. It's usually day 2 or 3. With being allergic to medications, it doesn't typically wait that long. So we generally are starting to see those breathing issues, the hives and so on, really pretty rapidly. So dosing is based off the amoxicillin component. So it's 250 3 times a day. That's not a medication I've ever used. 500 is BID or TID, depending on what you're treating. So say you're doing an internal hordeolum, you might want to do 500 milligrams BID. If you're doing a preseptal, then you're going to want to go to the maximum dose, which is 500 milligrams 3 times a day. I'm almost exclusively 875 twice a day. Why? Because it's the best dosing. It's also got the highest concentration. Bit of the downside to that, you can see the pills over the side. Augmentin 875 are pretty huge pills. They're pretty big pills. So you need to make sure your patient can actually swallow them. If they have any concerns about swallowing pills, then either go to a lower dose, or you can always put it into liquid form. I've done this for adults who say, I really don't like swallowing pills. It's easy enough to get it into liquid form as well. They can even get cherry flavored or lemon flavored, but you can put it into liquid form for people who, particularly for kids, but also for anyone who has a problem swallowing pills. I do not recommend that there are chewable tablets, but for most times you don't want them to break down that that capsule because it changes the absorption pattern. So now you start breaking down any coatings that are on them. In particular, if there's a clear coat on them, they are enteric coated, which means that they're designed to be absorbed in the intestines, not the gut. I highlighted that pediatric dosing on the bottom, not because I ever expect you to remember that, but it's important that we're not only indicating the height and the weight of the child, but also what dose you want to give. So there's a range on Augmentin from 45 to 90 milligrams per kilogram per day. So that's very much like doing 500 milligrams BID or TID. You're still going to need to tell the pharmacist what dose you want, right? So you're going to indicate to them the height and weight, and then say, I want to be at kind of the lower end, so the 45, or at a higher end at the 90. They'll do all the calculations and figure it out, but you still need to tell them a dose. So we have a 25-year-old white male patient presents with eye pain, redness, and watery discharge. He states that he feels that there's a pressure or ache behind his eyes. He's also been experiencing a headache. He does have some nasal discharge and facial pain. How would you treat this condition? All right, let's see what you said. So majority going with Augmentin, then some doing for allergy stuff. Tobradex, the miracle drop, right? You give it to anyone you have no idea what's going on, you give them Tobradex. I actually think that's on the package insert. If you don't know what's going on, give this drop. This is actually a sinus infection. It is actually one of the, I think, the more overlooked reason why patients come in with red eyes. In particular, if they're ever presenting saying, I've got a red eye and I feel pressure or ache behind my eyes, there's really nothing back there but orbital fat. So unless they actually have, some type of inner ear infection, then it's likely sinuses. The sinuses actually connect into that space to kind of equalize pressure. And patients who have sinus infections tend to feel this pressure or ache behind their eyes. So for me, that's a big trigger. So when we're talking about, patients coming in with red eyes, if there's that pressure and ache behind their eyes, there's really nothing back there to cause that. So you would want to start thinking about sinus infections. In particular, patients who have allergies, a lot of them do have sinus infections as well. I had a patient just a few weeks ago where the intern presented to me saying they have this red eye. And I said, well, did you ask about any kind of like pressure or ache? And she said, no, why? It's the red eye. And when I went in and I asked her about that, she said, oh yeah, I've got really bad sinus issues and she gets lots of congestion. And so we put her actually on Sudafed to help her for that, and said Sudafed would be a pretty good way to go that route to see whether or not this is really kind of sinus related. She already knew that she had sinus issues. And I said, well, that's the reason why you're feeling that pressure and the ache and also why you're developing the red eye as well. In this case, the majority of sinus infections are actually viral, but in this case, because of the nasal discharge and facial pain that's lasted for the last 2 or 3 weeks, then there's a greater chance it's actually bacterial in nature. So we have 8 sinuses that completely surround the eye. Any inflammation in any of those can result in that pressure and ache behind the eyes. The majority of them are viral. So greater than 90% of sinusitis are viral in nature. However, this is one of the actually common reasons why we're developing resistance issues, because about 1 in 5 antibiotic prescriptions for adults, making it the 5th most common reason for antibiotic prescriptions, is because people are treating a sinus infection, which is likely viral, with an antibiotic. There are a couple conditions that would indicate that it's potentially bacterial and not viral. And that's a temperature of more than 102 degrees Fahrenheit or 38 degrees centigrade. We probably all have the ability to check temperature in our offices now. If a patient has a temperature of more than 102 degrees, then you're starting to think it's bacterial. So it separates out between viral infections and bacterial infections. The 102 degrees is also a crucial cutoff between, say, like a preseptal cellulitis and, say, an orbital cellulitis. If the patient has symptoms that last for 10 days without improvement, or they're getting nasal discharge or facial pain, then again, we're much more likely to think it's bacterial in nature. One quick check on these, again, if you're thinking it might be sinus related, is to do Sudafed. I think all of us kind of saw that pseudoephedrine, that it's really the only way you're going to take care of that. The phenylephrine is really not all that effective. So if you're going to want to really take care of this, you're going to need to go into the pseudoephedrine. Augmentin, it used to be amoxicillin was the treatment for sinus infections. It's now Augmentin. Again, the most likely bug that's causing this is staph, right? So we want to make sure that we're covering staph. For adults, again, at a 5 to 7 day range, kids can still be a little bit longer than that. So I remember this young boy came in. He's 6 years old. His dad brought him in because he's got another hordeolum. Obviously, that's not a 6-year-old eye. But his dad said, he's been getting quite a few styes in the past, year or so. They're really painful. We're actually really doing some warm compresses, but is there anything else we can do to try to help resolve these styes? Because we keep bringing my son in for them. So what would you recommend? All right, let's see what you said. So majority went with Augmentin. The next big group in there is Doxy, and then azithromycin, and kind of a smattering of like Torbidex, Vigamox, warm compresses. I do think warm compresses are really important, but in this case, because he's been having multiple ones, I think we need to kind of treat what's kind of going on. He looks like he has either an overabundance of staph or something's causing these infections. So I do think the warm compresses and your digital massage and washes are really important. But if they're getting multiple ones, I think we need to address it differently. I do think the Torbidex is a good indication that the patient has blepharitis to help reduce the blepharitis, but we really need to treat this orally. I went with Augmentin. It's really my go-to on this one. Azithromycin, I like that as a Z-Pack because it's really good dosing. Just remember, though, that staph is becoming pretty resistant to azithromycin. So in some ways, it might be a bit of hit or miss for that one. So I see some people chose doxycycline as well. So I've got a question here for you. Which of the following statements is incorrect with respect to the tetracycline group of antibiotics? All right, let's see what you said. Actually the last one, everyone chose the last one, and that actually is a correct answer. So if we would have gone back to this previous one, remember the indication for tetracyclines is not to prescribe anyone under the age of 8. So I would have picked on this group before, but now the indication is that you can use doxycycline regardless of age as long as it's less than 21 days. We know that they actually won't cause teeth discoloration. So I'm not saying willy-nilly prescribing doxy for everyone, but as long as it's less than 21 days, you can prescribe doxy to any age. Minocycline or tetracycline are not included in that, but you can actually prescribe doxycycline to regardless of age as long as it's less than 21 days. So the incorrect answer is it really doesn't influence blood sugar levels at all. It can cause discoloration of teeth. In particular, tetracycline will do that. It can result in intracranial hypertension. That's more into kind of the minocycline group. Minocycline can cross the blood-brain barrier, and so can result in kind of neurological effects. So it's one of the reasons why I don't prescribe minocycline, because patients can get lots of vestibular side effects from it. It does increase in photosensitivity, so making sure that you're telling patients who are taking doxy to do some protection. But remember now, doxy can be used regardless of age, as long as it's less than 21 days. Doxy had kind of been reserved in kids more for those tick-borne diseases, for like the Rocky Mountain spotted fever or Lyme disease, but it doesn't have to be necessarily just excluded or just reserved for those conditions. As long as it's less than 21 days, you can prescribe it. So for styes, I actually had 2 styes in the past couple weeks. I know for me, warm compresses are not going to solve it. I will go into the chalazion stage. And the last time I had a chalazion, I allowed my 3rd-year interns to practice their injection skills on me. Probably not going to happen again. The time before that, I had one of the faculty members do an excision on me, and I actually passed out in front of students, which is so not good for my rep. So I don't want to do that either. So warm compresses don't work for me. So I have to actually go the oral route. In my lumps and bumps clinic, when patients come in and they've done the warm compresses and it didn't resolve and now they're in the chalazing stage, I tell them really the next time this happens, we need to go into the oral antibiotics because likely warm compresses aren't going to work for you. So I'm a big Augmentin fan. So I typically do 875 twice a day. Keflex is a great option as well because it's got great soft tissue penetration. Just the downside is the dosing is a little bit higher. I put Doxy on there and a question mark beside it. I have a bit of a bias against Doxy. I don't necessarily think it works really well for styes. And that's mainly because I have patients coming into my lumps and bumps clinic who were on Doxy and it didn't resolve their sty. And I suspect there's millions of other people it did work for. I just see the ones that come in that Doxy didn't work for them. So I will admit to having a bias against it. I'm not saying you can't use it. It just wouldn't be what I would go to as first line. Topical antibiotics, I don't know if they're all that effective. They may be helpful for taking care of the blepharitis that might be causing the styes, but ultimately they're really not going to get into that gland and start taking care of that infection. We do recommend warm compresses and lid washes. We really need to make sure that we're recommending some type of commercially available mask. There's enough studies out there that show that a warm compress doesn't provide enough heat in order to really change anything. You need 5 minutes of sustained heat up around 108 degrees in order for it to really be effective. So all the commercially available masks will work. Just make sure that we're not doing the washcloth and microwave because that's really not all that effective. So dacryocystitis, this is an infection of the lacrimal gland or lacrimal sac. It tends to be very painful. It tends to be much more into the nasal part of the person's eye. To kind of separate that out between say a preseptal cellulitis. So if you looked at this, you're kind of going, that could be a preseptal because it's involving the entire lid. Well, one way you'd want to separate out those two is if you actually push on that area and you get pus coming out of the punctum, then it is a dacryocystitis. The patient will absolutely not be happy with you that you pressed on it. And it's important that you differentiate it between being a dacryocystitis and being a preseptal, because even though the treatment's the same for both of them, is that it's what happens after is very different. The recommendation is that after you treat it, say with your oral antibiotic, is you send them to oculoplastics because they're going to do a silicone tube intubation for basically keeping that system open. So I work with a very amazing oculoplastic surgeon here in Portland, Dr. Sullivan, and he's the one who really taught me this. He said, Blair, go ahead and treat them with the oral antibiotics, but after that, send them to me because we haven't resolved the infection, but not necessarily the blockage that's in the system. And there's kind of enough evidence to show that patients have a dacryocystitis. There's enough inflammation to potentially cause that system to shut down. So he said what he does, we tend to think DCRs where they do a cut. He said, no, I just take a little silicone tube and I'll actually just run it right through the system. If I can't get it through, then I'll have to go in there and operate. But typically he said I can just run a silicone tube through there and it keeps it open. So we have a 13-year-old female patient comes in with acute onset swollen and painful lower lid. VAs are good, EOMs are full. Patient does have a low-grade fever of 100 degrees Fahrenheit. What's your diagnosis? All right, let's see what she said. So majority went with preseptal cellulitis, and I would agree with that. I might have caught a couple of you on the orbital because of the temperature. Remember, it's 102 degrees is the crucial cutoff. There is some discomfort on kind of eye movements, but ultimately, remember with an orbital, it's restricted and painful eye movements. Patients who have an orbital cellulitis tend to be really sick people. So they have not only a temperature, but they're going to have decreased VA, they're going to have proptosis, they're going to have an APD. A lot of times orbital cellulitis aren't coming into you, they're going to the emergency room. But orbital cellulitis patients tend to be pretty systemically sick. An internal hordeolum, I don't think would be involving that whole kind of entire lid part to it. And remember, a dacroadenitis is an infection of the lacrimal gland, which would be superior and not inferior. So with preseptal cellulitis, I think the majority of these are coming from an internal hordeolum that's fistula to the tissue that surrounds it, which means we have to be a little bit careful when we tell patients to do warm compresses and digital massage, that we don't want them to get in there and start pressing really hard because it can actually break and fistula to the tissue that surrounds them. Other potential causes are things like, sinus infections. If you break the tissue and obviously bugs get in there, that can be a possibility as well. But I think majority of them will come from internal hordeola that now have kind of broken through and infected the rest of the lid. I do practice up in Alaska. So when I get a break from the school, I go up to Alaska and I practice in a private office in Anchorage. I do that 5 or 6 times a year. And probably about 3 years ago now, I had a patient come in who had a really large chalazion/hordeolum on his upper lid. And he wanted me to do an excision on it. And I said, yeah, great, we'll get you prepared for that. But as I was kind of palpating it, he goes, ooh, that's still a little bit tender. I said, well, you still may have some active infection there. So let's put you on an antibiotic for a week and then I'll do the excision for you. So as I had him in the slip lamp, I decided to kind of flip his lid over to take a look at it, and it broke open and all this pus started oozing out. Well, if it had gone any other direction, now he's got a preseptal, right? So to me, I think that's the major cause for patients to develop a preseptal is from an internal hordeolum. Again, remembering with patients with digital massage, just not to get in there and start pressing really hard because it could break laterally. I don't lance infections. If we had gone back to, let me kind of skip back here to this one where there's an obvious head to it, I will not necessarily lance it, but I'll kind of maybe take a needle and just kind of pop it a little bit and squeeze out the guts from it. But if it's more deep, I don't actually puncture the skin because again, you have a greater chance to now can result in a preseptal. First of all, it's extremely painful. So patients say that they want it like lanced until you actually lance it and they don't really want you to have lanced it. If it has a head on it like that, again, I'll kind of just scrape it off a little bit and then kind of squeeze out the guts from it. But for internal ones, I would not recommend lancing them because you could definitely increase the chance for a preseptal. So if you're going to lance, then I'd probably say you should have them on an oral antibiotic anyway. And at that point, just let the oral antibiotic do its work. So there's your differences between orbitals and preseptals. Remember with orbital infections, there's decreased VA, there's marked proptosis, pupils tends to have an APD present. It's restricted and painful eye movement and temperature more than 102 degrees. With your preseptals, again, tend to have normal acuities. There's no proptosis. There may be some chemosis and hyperemia, but there's going to be no abnormalities to the pupils. There will be no really pain issues. And temperature is typically less than 102 degrees. All right. We've now determined that our 13-year-old's preseptal is secondary to our MRSA infection. Patient doesn't have any allergies. What would you recommend? All right, let's see what you said. So majority went with C, which is Bactrim or Septra, and that's really, from this choice, is your correct answer. So remember, methicillin-resistant staph, anything in the penicillin group is not going to really be that effective. So augmentin, which is amoxicillin, not going to work. Caflex is part of the penicillin family, again, not likely going to work. And I'd actually really like to see that final group there, those who chose Cipro, to kind of take that answer off completely. It's contraindicated in patients under the age of 18, so you can't really use it in that group anyway. And in addition to that, there's so many toxicity issues with the oral fluoroquinolones that even the FDA's come out and said, even if an oral fluoroquinolone is your best option, find something else to use because of the side effect profile. They can result in seizures, neurological side effects. They can result in rupturing of tendons. They can change blood sugar levels. Topical wise, they're perfectly fine. But I think in optometry, there's really not much reason for us to ever prescribe an oral fluoroquinolone just because of the potential side effect profiles. In addition to that, you can't use it in this patient anyway because it's contraindicated in patients under the age of 13. So Bactrim would be your best option in this case. We'll talk about that a little bit later, but Bactrim is a combination of trimethoprim and sulfamethoxazole. Now, your patient can have a sulfa allergy because obviously it's got a sulfa component to it, but those two medications together are synergistic, and actually the trimethoprim is giving you that MRSA activity. So my go-to for a Preceptal will be Augmentin. So 500 milligrams TID or 875 twice a day. She is 13, so we go into the adult dosing, so for 5 to 7 days. Now, if it's the child is younger or the kid is febrile, then you might want to consider hospitalizing them to make sure that they get an IV preparation of antibiotic, just because the concern that we can have potential spread to become an orbital. Again, if there's any of those things that we considered originally from the MRSA, so, person was recently hospitalized, you've tried Augmentin and it's not working, any of those things we talked about before, then you might want to consider doing Bactrim or Septra as your first line. So I get asked quite often, why don't we just use Bactrim or Septra for all Preceptals and just kind of don't worry about if it's MRSA or not, just treat it. Will it treat a normal infection? Yeah, it would, but amoxicillin's got much better soft tissue penetration and a lot less side effect profile, right? So if you're giving Bactrim, so Bactrim and Septra, they're just a brand name for that product. If you give one of those and you have to be worried about the sulfa component, you have to be more worried about Stevens-Johnson syndrome. So unless there's any of those risk factors for potential MRSA infection, then Augmentin or Keflex would be a much better option because of the much better penetration into the soft tissues. So we'll move on to the cephalosporins. They are part of the penicillin group. They are beta-lactam antibiotics, so they effectively have the same mode of action. A lot of the same resistance mechanisms are in place for them as well. They are classified in 5 different generations. So as you go up in generation, you go up in gram-negative coverage, and you typically go up a significant increase in cost as well. So your 5th generation ones got a lot more gram-negative coverage, but they also tend to be pretty expensive. They're typically more IV-IM administrations. There's not, a lot of these medications aren't well orally absorbed. So majority of them we tend to think about is like Recephin, which is an injection. But there are kind of 3 of them that you do want to remember. We do have to remember that because they're part of the penicillin group, if patients do have a penicillin allergy, then we really don't necessarily want to think about cephalosporins as first line therapy for them, potential for cross-reactivity. The recent evidence shows that there's really not probably a lot of cross-reactivity between them. It's thought to be, used to be about 10%. Now it's thought to be closer down to 3%, which is probably just the fact that the patient is allergic to the cephalosporin and really makes not much difference if they're allergic to the penicillin or not. If you are going to prescribe, or you do want to prescribe a cephalosporin, then make sure it's just not a first generation cephalosporin, something like Keflex. That's the ones that are going to have the most chance to cross-react with a penicillin allergy. So you'd want to go into make sure like a 2nd or 3rd gen, so like Ceclor or Omnicef, and you're going to dramatically reduce your chance that there's actually going to be any cross-reactivity between those 2. So the big 3 that you really want to remember are Keflex, so cephalexin, Cefaclor, which is Ceclor, and Cefdinir, which is Omnicef. Omnicef is no longer available as a brand name, but is available as the generic. You can see when we get into the 5th generation ones that these are used potentially for like MRSA infections, but they tend to be very costly and not something we'd likely probably be prescribing in. So again, the big 3 that you want to remember are Keflex, Ceclor, Omnicef. These are the ones that are 3 really well orally absorbed medications. So for Keflex, dermatology really loves Keflex because of the fact that it's got great soft tissue penetration. Typical adult dosing is 500 milligrams every 6 hours, so 4 times a day. Remember we talked about, attacking to kill all, so don't kind of lethally dose medications. And this is the one I see that's often done that way, which is why I tend to like Augmentin twice a day because it's easy to take. But I do see people prescribing this 2 to 3 times a day. And yeah, it might be effective for treating an internal hordeolum and so on. But my recommendation is you kind of go to that full dose and make sure that you actually treat the bug and you kill that it's there. So this is the one I think that often is either not taken properly by your patients or it's not prescribed to the full amount. Again, I think you probably could get away with doing internal hordeum 3 times a day. But then you have to make sure your patient's actually taking it 3 times a day. If they're only taking it 2, then you might not have enough in the system. So this is the one if you're going to do, I really kind of would recommend that you do the 4 times a day, just to make sure that your patient's taking that entire dose, and the fact that you're not getting into that potential, that you're not actually killing all the bugs that are there. There is an extended release formulation. The 750 is just really pricey. C-chlor, this is a 2nd generation one. We're starting to see a lot more C-chlor being prescribed, mainly because it's becoming more cost effective. And in addition to that, it's better dosing. And there has been some potential concern for resistance with staff to Keflex, because Keflex is so widely prescribed. There's some concerns that there might be some resistance developing there. So I'm starting to see a lot more C-chlor being prescribed. It comes in 250 and 500 milligram immediate release, and there's also 500 milligram sustained release. If the extended release one is basically twice a day, for your 250 to 500, typically 3 times a day. So for, say, a preseptal cellulitis, it'd probably be in that 500 milligrams 3 times a day. So Omnicef, again, is no longer available in the US as a brand name. And if you happen to be from Canada, it's not actually available in Canada. I actually really do like this medication because of the way you can dose it. It's 600 milligrams per day. They come in 300 milligram tablets or capsules, and you can either do it twice a day or you can take both of them at the same time. And this is one of the few antibiotics that you can take as once, and it's effective as doing twice a day dosing. Absolutely do not tell your patients that they can do that with other medications, because they don't work that way. Particularly when it comes to the your penicillins like amoxicillin, its half-life is really short in the system. So that's why you're doing multiple dosages, to keep those levels high enough in order to take care of the infection. This is one antibiotic where you can take either both pills at the same time, which, basically for compliance is going to be the best route. They just take both pills at the same time, or they can separate them out by 12 hours. So it can be twice a day or just all at one time. I threw Suprax down in there too. Not something you're likely ever going to prescribe. This is more typically reserved for patients who have a gonococcal infection and the injection is not available for them. So the treatment for gonorrhea is an injection of Recefin. If that's not available, then they can be prescribed Suprax, which is an oral medication. The dose used to be 400 milligrams. Now it's actually been doubled to 800 to start taking care of those gonococcal infections. But again, not something that you're likely going to prescribe. All right, so we have a 25-year-old male patient presents with a purulent red eye. Upon further questioning, reports recent painful urination, tender and sore testicles, and some discharge. Which of the following is the most appropriate treatment? Patient has no drug allergies. All right, let's see what you said. So majority going with azithromycin single gram dose. We've also got an injection of Recefin. We got penicillin G. We kind of a little bit of smattering of everything. So what we're potentially thinking in this case is, I wish I could ask you guys this question, because I really would like to see that difference in what people are thinking. Some are thinking this is a chlamydial infection. Some are thinking it's a gonococcal infection. My question to you is, do you know for sure which it is? And in this case, it's likely more gonococcal because of the tender and sore testicles, but you don't necessarily know that's actually gonococcal versus chlamydial. The majority of you chose single gram dose of azithromycin. It's no longer the standard of care for either one, for gonorrhea or chlamydia. It was for chlamydia until recently, until 2021. Now the recommendation for chlamydial infections is 100 milligrams of doxy twice a day for 7 days. That is now standard of care for chlamydial infections. So for me, my concern is when we have these patients with these purulent red eyes and you're thinking that there might be an STI involved, yeah, you can prescribe the antibiotics for it, but you shouldn't, because you don't know which one this is. The treatment for gonococcal is an injection of Recefin, which you're not going to be doing. The treatment for chlamydia is doxycycline. So when azithromycin single gram dose treated either one of those, chlamydia or gonococcal, then it made sense that you potentially would treat them. But now it's not the treatment for either one of them, or not mainstay treatment anyway. So for me, you really, I would really hesitate in you treating these at the office without getting testing done. Remember, these are mandatory reported conditions as well. In addition to that, sexual partners need to be treated. And that's really kind of not my comfort zone, would be kind of contacting sexual partners and telling them that they've been exposed. So, really get them, send them to their primary care physician, or they can go to an STI clinic, which is more anonymous. In the STI clinics, they will actually, take all that information, and say a person met someone off one of the apps. They don't even necessarily need to know their name. The STI clinics have access to those apps, and will actually send an email or a message to those persons on their profile on the apps, and say that you potentially been exposed to someone who has syphilis or so on, and you should get tested. So to me, you really shouldn't be treating these out of your office. They should be sent off for testing, so they get the appropriate testing done and then the appropriate treatment done. So your hyperacute conjunctivitis is when you got this kind of massive purulent discharge that's coming out. They tend to actually have positive lymph nodes as well. We're going to kind of do a quick, so hopefully you'll play along with me, but let's check lymph nodes, right? So what you're going to do is take your 3 fingers. I want you to put them in front of your ear. I want you to open your jaw. And that cavity that you find there, that's your preauricular node. Why you're taking your 3 fingers is because you really want to squish them. You want to squish the lymph nodes, should be squishy. And what you're looking for is it to be either tender or that there's a solid knot there. If they have a positive node, they're really not going to want you to be touching on them, but get them open their jaw and find that little cavity that's there. Then you're going to come down to the jawbone. Much easier to do on someone else than to do on you. And what you're going to do is from the jawbone, you're going to press in. And you really need to kind of get into that space there. A lot of times you actually see your patient's head go up because you need to dig into that space. Then you come halfway down the jaw, and then you're going to press in. These are submandibulars, right? So the preauriculars and the submandibulars tend to drain the eye. So if you had a person come in with acute onset red eye and you're thinking it's viral, say like EKC, then typically preauriculars or submandibulars are activated. If someone had a cold or a flu recently, then the tonsillars will be activated. But with these kind of big bacterial infections, they potentially have a node involvement. For me, it's really important to check lymph nodes. It takes you 30 seconds to do. In addition to that, while you're there, I'd probably do a gross examination of their eyes too. Get them to look up, look down, look for the pattern of redness and so on that's there. So say you have sectorial redness. Well, that's not a viral conjunctivitis. That's more like episcleritis. So sometimes we kind of get into slit lamp and we don't take a look at the overall view. So kind of get them look up, look down, check lymph nodes. Takes you 30 seconds to do, but it gives you a ton of information. The nucleic acid amplification test, this is your standard testing for chlamydia and gonorrhea. It really is your gold standard. It's the most sensitive and specific for those two. So for gonorrhea, humans are really the only reservoir for gonorrhea. So we just kind of keep reinfecting ourselves. This is become an urgent threat in the CDC's list of antibiotic resistance bugs. Gonorrhea is really good at figuring out antibiotics and getting around them. And the downside is that people who aren't appropriately treated either reinfect themselves from sexual partners or they're incompletely treated. There is actually a strain of gonococcal infection that's now in Canada and the US that is multi-resistant. There's really no drug that will treat it. They still test positive for gonorrhea. It's just that there's nothing that can be treated with it because it's pretty much resistant to everything. The original dosing for gonorrhea was 250 milligrams of Versephin. Now it's 500. So they've doubled the dose. In Canada, their ceftriaxone still might be used, but it's still at the 250, not the 500. They typically add zithromycin into that mix as well. But in the US, the standard of care is really Versephin. So ceftriaxone, 500 milligrams injection is a single dose. If there's a concern for chlamydial infections, they might put a concurrent, doxy over top of that. But again, hopefully you're getting them tested so that they can figure out if they want which one they have. And sometimes they go hand in hand and there's both of them there. And remember, the Versephin won't treat the chlamydial infection. They'll have to be on doxy as well. They should be tested for other STIs. Sexual partners must be tested and treated. And remember, this is a mandatory reported condition to your state or local health department. So again, to me, that's really important because if you don't do the testing, then you can't report it. And I think there's a lot of cases out there that are underreported because they're just not reported because people aren't doing the testing for it. If there's ocular involvement, it's actually 1 gram is the recommended treatment for it. So if people have, for this one, this is basically for the urogenital one. If there's actually ocular involvement, so the patient have the purulent discharge, the dose is actually 1 gram. I don't know if I mentioned that in one of my slides, but it's 1 gram if there's ocular involvement. If it's just the urogenital one, then it's 500 milligrams injection. I mentioned before that if patients aren't able to get the Recefin injection, or maybe they're allergic to Recefin, then they can do Suprax, which is used to be 400 milligrams, it's now 800 milligrams. Oh, there's the ocular one. So if there's ocular infection as well, it's actually 1 gram injection as 1 dose. We do want to do some topical antibiotics over top of it as well. Because of the purulent discharge, we don't want to give them a chance that they're going to, develop an ulcer and perforate, but you can't just do the topicals on its own. It has to be treated systemically as well. For chlamydia, standard care used to be azithromycin. Now it's actually doxycycline, 100 milligrams twice a day for 7 days. In Canada, they can do doxy or azithromycin, but in the US, it's primarily doxy. If the person's allergic to doxy, then the alternative treatments are azithromycin. And why this came about is because they found resistant strains, in particular men who have sex with men. They found a resistant strain, but they're now starting to find it as well as men who have sex with women as well. And so now they've kind of just uniformly said that the standard of care for treatment for doxy or for chlamydia is doxycycline, 100 milligrams twice a day. Again, sexual partners must be tested and treated. And again, it's also a mandatory reported condition as well. We want to treat systemically. You might want to do a topical antibiotic over top as well if there's purulent discharge. For the neonates, we traditionally use azithromycin or erythromycin for that. Unfortunately, it's becoming really the chlamydial organism is actually becoming really pretty resistant to erythromycin. So the best way to kind of get around that for the neonates is to either treat the mother before birth or treat the baby after, and that's through a systemic preparation. So other uses for your cephalosporins, again, treating things like adaptive cystitis, preseptal cellulitis. Then we get into orbital cellulitis. Again, something you're not likely to be treating, but may come into your office. You want to make sure that you can diagnose it. So remember, this patient's going to have, they're going to be systemically sick. They're going to have proptosis. They're going to have an APD. They're going to have reduced VAs. If we're suspecting that, then it has to be an IV preparation. That's what they're going to be sent for. Staph and strep tend to be most common isolates that are found for orbital cellulitis. The treatment is vancomycin IV for a few days, plus one of the following. So they do either ceftriaxone, which is Recefin, or cefotaximine. The IV therapies continue for 3 or 5 days. And then at that point, they're going to be put on oral antibiotics, typically things like clindamycin. So clindamycin is used for patients who have a potential MRSA infection. It's a synthetic antibiotic really designed for MRSA infections. Remember, Bactrim or Septra is also indicated for MRSA. So we're giving that additional oral coverage to make sure that there's MRSA not present. And then they'll be given either Augmentin or one of the other cephalosporins. So which of the following is the most common type of endophthalmitis? So if you're to see endophthalmitis in your office, what's the likely underlying cause for it? All right, that's what you said. And it's actually now post-intravitreal injection. So cataract surgery used to be the #1. It's now post-intravitreal injection, and mainly because they're just doing so many more injections for like AMD and diabetes and so on. Retina people pretty much just all they do all day is intravitreal injections. So it's now actually post-intravitreal injection is the most likely cause for endophthalmitis. Tends to be more gram-positive bugs, again, because that's the majority of bugs that are on the lids. So 95% of endophthalmitis are gram-positive, which is good because they tend to be easier to treat. Gram-negative bugs are actually extremely difficult to treat. So post-injection endophthalmitis cases now exceed post-cataract surgery endophthalmitis, and that's actually been for quite a while at this point in time. What you're likely going to see is probably the post-cataract patients that you get more concerned about. Remember, endophthalmitis is not likely going to be present on day one post-op cataract, but it's usually type day 2 or 3. If you look at kind of the symptoms that patients are going to have, we tend to think about the pain and the red eye, but if they are really observant, it's actually decreased VA. Unfortunately, we know that patients in VA is not really a good indicator because patients aren't necessarily all that sensitive to changes in VA. But if you bring them back for that 1 day post-op and they're nailing 20/20 and they start to see that the vision decreases, that's really kind of the most likely sign that they're going to see is the decrease in vision. Most people are coming back because of the pain or the redness. All of these, if they're happening, obviously you want to bring the patient back, but really do educate your patients that to be really observant of their vision. And if it starts to decrease, that they should come back. Treatment for endophthalmitis is they're going to go in there and basically remove the vitreous. When they remove the vitreous, they're going to culture that to see what bugs are in there. But they're going to do an injection or intravitreal injection of vancomycin. They're also going to do Fortaz or amikacin. Amikacin can only be done once, though, because of toxicity issues. So they'll do the vancomycin to make sure there's no MRSA component to it. And then they'll also do Fortaz or amikacin. They'll also do intravitreal steroids, mainly because this is a closed system. And if there's that massive infection, it's so kind of a question I would have for you is, can you have an inflammation without an infection? And the answer is yes. Can you have an infection without inflammation? And the answer is no. So because you have a closed system, they're producing a lot of information. And a lot of times that's what the damage is happening from, is from that inflammation. And it's sometimes even hard to treat the bacterial infection. If you have so many inflammatory mediators in play, you can't actually treat the infection. So they typically will do a steroid to kind of reduce that inflammation and then also help to take care of the infection. They're also going to do, in addition to the intravitreal, they'll do subconjunctival injections, they'll do topical medications, they might even do orals. Basically, they'll throw everything in the kitchen sink at them to see whether or not they can save the eye. So vancomycin is increasingly important because it's really what we're using for MRSA. Systemic-wise, there has been some resistance issues found with MRSA infections to vancomycin. Topical-wise, there's been found to be no resistance. So if you really do believe the patient has a MRSA infection, then vancomycin is really your gold standard for that because there's no resistance been found in it. The other member of this group is bacitracin. And bacitracin is only a topical preparation because it's way too toxic to use systemic-wise. You can't get systemic bacitracin because of nephrotoxicity. But for vancomycin, topical-wise, you're going to want to get it. They'll have to compound it up from the powder form, which they're going to use for the injection, and they have to then put it into an ophthalmic drop. You have to be a little bit know who your compounding pharmacies are. Not all compounding pharmacies can do ophthalmic products. All of them can do the skin ones, but they need actually special fume hoods and so on to do the ophthalmic products. So not all compounding pharmacies will be able to do an eye drop for you. Vancomycin is typically given as an infusion because it can actually result in lots of body changes. They can develop this flush and blood pressure issues. So they can't just give them a whole bolus of vancomycin one time. It has to be done over an infusion, typically over about 45 minutes to an hour. There is actually an oral preparation of vancomycin. It just doesn't work very well. It doesn't get absorbed well enough through the gut, which is why it's primarily used as an IV medication. So used for things like orbital cellulitis, endophthalmitis. Bacitracin, I love this picture because on a scale of 1 through 4, this is about 150. Hopefully your patients would never get to this point. I did have a patient who, she's interesting. She loves her fake eyelashes, but she gets styes and then chalazions from them. And so I've injected her now 6 times for her chalazions, and she doesn't like the injections. She gets quite freaked out by them. And so I told her, you really need to stop the fake eyelashes. So the last time that she came in, the intern went to her and, she said, oh, I'm not using fake eyelashes anymore. I'm going, I can see them on your eyes. Like they're there. So I'm not too sure why you're lying to me because I actually can see them there. I'm going to look at your eye and I can actually see them there. And then she had really this crusting stuff. And so she, of course, swore that she was doing her warm compresses and massage and so on. I actually had to go in with forceps and actually peel the scab off of her lids to be able to get to the tissue underneath of it. So if you do have patients that do the fake eyelashes, really recommend that they're getting someone who's reputable, because it's usually the glue that's causing that issue. But they are a bigger chance for patients to develop chalazions and hordeolas because they're plugging up those glands. Bacitracin is really only used as a topical preparation. Amazing gram-positive coverage, has no gram-negative coverage. If you want gram-negative coverage, you're going to need to add polymyxin B into it, which is polysporin. All right, switch gears here a little bit. I'm going to kind of pick up the pace because we got only about 20 minutes left and I got a lot of stuff to get through. This is a case for Dr. Tammy Thon, who's a really good friend of mine, a brilliant optometrist. We did a lecture at Academy a few years ago called Fact or Fiction. And what we did was did the polling stuff like we're doing for you now. Said, how do you treat a preseptal cellulitis? How do you treat a corneal ulcer? But we didn't show the audience their responses. And then we went to literature and said, this is what the literature says you should do, right? And then we kind of repolled the audience and see whether or not we changed their mind. So this is one of the cases that Tammy had. 67-year-old female patient come in for an eye exam basically 3 days previously. Everything was fine. The next day, she started to develop some headaches and some visual field loss. She came back to Tammy. No medical history, no medications. Would you agree that there's a visual field defect? Yep, I think all of us would agree that. Where's the problem? Well, there's your problem. Your patient's had an occipital lobe stroke. So my question for you is, post-occipital stroke, in addition to visual field testing, what's your management? All right, continue to answer, but we're going to show you your responses here. All right, I think majority are going with baby aspirin. This really is a systemic antibiotic lecture, so you probably should choose minocycline. And minocycline is actually the correct answer. So why minocycline? Because your tetracycline group actually has neuroprotective abilities. It has anti-inflammatory properties, which could be beneficial. It has to be minocycline and not doxy, because remember I mentioned earlier that minocycline crosses the blood-brain barrier, doxy doesn't, right? So to get into that area, it's going to have to be minocycline that does that. So let's talk a little bit about that. Minocycline can reduce MMP9 levels, which are really powerful inflammatory mediators. They're reducing inflammation. Reduction of microglial activation, that's effectively like getting scar tissue, right? So if you reduce scar tissue, then you potentially improve function. They are potent nitric oxide producers, which are free radical scavengers. They also inhibit apoptic cell death. And I see apoptic cell death as if you traumatize a cell, it just wants to kind of die. It just wants to go through a programmed cell death. Well, if you can intervene in that and keep the cell alive, then obviously it's going to be protective. So we're going to look at the neurology data first. And there are several studies that looked at the use of minocycline in patients who had an acute stroke. This is the first study I'll talk to you about. It's patients who had an acute ischemic stroke. They didn't look at hemorrhagic strokes, but just ischemic strokes, though they don't think there's much difference between the two, but these are ischemic strokes. Within 24 to 48 hours presented to the emergency room, and they were given minocycline 200 milligrams for 5 days. And then they were quantified on what's called the NIH stroke scale, which is what the scale's on the right there. And so, the higher the score, the worse the stroke. So 0 to 1 is completely resolved or nearly complete improvement. 2 to 7 is mild. 8 to 14 is moderate. Anything greater than 15 is considered severe. There's 3 studies on here, but the one we're talking about right now is the top one. So you can see that patients started at 7.5 and 7.6, so almost into that moderate category. The minocycline group given 200 milligrams of minocycline for 5 days. They're evaluated day 7, day 30, and day 90. You can see that in the top group, they're down to 1.6, so almost to the point of completely resolved, where your control group is still sitting about 6.5. Next study, again, lower numbers are better. Started at 2.8 in the minocycline group, ended up at 0.9. In the control group, started at 2 and actually got worse. The third study, higher numbers are better in this case. Started off at 70, ended up at 95. And the control group started at 64 and ended up at 78. So the neurology data is saying this is potentially neuroprotective. They're giving it to them in that 24 to 48 hours. Their overall function was improved as compared to not doing anything at all. So how does that apply to us? Well, I can only find one really clinical report or case report in the literature, and that was this one. So 77-year-old male patient had an occipital stroke 3 weeks previously. He was watching a news program about potential use of minocycline for stroke patients. So he contacted his optometrist and said, I want to try this minocycline stuff. So they gave him minocycline twice a day for 5 days. Would you agree that there is a visual field defect there? I think we would all agree that it's true. So this is him shortly after treatment. Here's him a year later. Now, I have nothing else kind of really to back this up. There's no clinical trials on this one. I do have a folder of about 15 different cases with that I've been giving this lecture, and doctors have been sending me cases saying, yep, I saw an improvement. I'm sure there's lots of people out there that tried it and didn't work. But to me, why this is so important is because this patient, particularly in Oregon, doesn't have a driver's license anymore because he doesn't have 110 degrees of continuous visual field. So he no longer has a driver's license. This person does. And all the patients that were tried in these trials, not one patient got worse. So unless they're allergic to minocycline, your side effect profile is basically zero. So we're really talking that cost risk benefit in this case. I would absolutely not promise them anything. I would not promise them that, that anything's going to change. But I do think that there's a potential for improvement. And if you have no potential risk to the patient, then I'm not too sure why you wouldn't at least try. So questions you're probably going to ask is, well, what time period? Well, we really don't know. Most of these trials were within 3 months. So I say probably absolutely within 3 months is really the only time you're going to see the effect. I did have one doctor email me. She had a patient at 6 months post-stroke that she did and saw improvement in the visual field. I think that's probably pushing it, but as close to the time of the stroke as possible. You're going to ask me, can you repeat it again? No evidence of that. But again, if there's really not a side effect profile, then again, I'm not too sure why you couldn't. You're going to ask me about potentially other conditions. The only one I think it might, and that's just my own personal opinion, would be ischemic optic neuropathy, because I think those processes are pretty similar, acute stroke with an AION. But again, no evidence of that either. So this for me is kind of food for thought for you guys. I'm not saying that you should do this or not do this, but I also have the articles. So if you want to send me an email, I'm happy to send those articles to you as well. I guess the big part for me is if you can potentially improve vision and there's really not a side effect profile to them, then I'm not too sure why you wouldn't try. So we're getting into protein synthesis inhibitors group. This is your tetracycline group. Clindamycin's in this group as well as chloramphenicol. These are attacking the bacterial ribosome, some units, which are again different than human cells. Side effects of tetracyclines, we traditionally know that we don't want to use them in pregnant females or, women who are breastfeeding. Traditional wisdom has been children under the age of 8. They're contraindicated. They've been primarily used for tick-borne diseases now, for like Rocky Mountain spotted fever, for Lyme disease, but they are now used for MRSA infections. They are considered first-line treatment for MRSA infections. Lots of GI issues, particularly with doxycycline. The vestibular side effects is really going to come from minocycline, not doxy. This is what I was mentioning before. So they've done several studies showing that, recommendations have changed stating doxy, but no other tetracycline can be used for short courses less than 21 days, regardless of age. So we don't necessarily have to reserve them for the tick-borne diseases. Again, I'm not necessarily saying that you should be prescribing doxy for all your kids, but if you do feel that's going to be the most effective for them, then there's not a contraindication as long as you're using it for less than 21 days. It is used for MRSA. Doxy is 100 milligrams twice a day. Minocycline is 200 milligrams orally once, then 100 milligrams orally twice a day. My rule of thumb for doxy, do not take before lying down. So for at least, greater than 2 hours before they lie down to get rid of some of the GI issues that they can have. Avoid calcium and antacids. Do not take with dairy. I'll put a little bit of question mark on that one. Dairy will decrease absorption, but if they're having GI issues, it might coat their stomach. Absolutely take this with food. If you don't take it with food, it's going to tear up their stomach. And absolutely recommend sun protection for them as well. Acne rosacea, typically more common in women, but much more aggressive in men. In women, typically seen over their cheeks, men typically over the bridge of their nose, up over their brow. We're typically just almost calling this ocular rosacea or rosacea. Ocular rosacea is kind of included in this one because 85% or higher of patients who have acne rosacea have ocular manifestations to it as well. In particular, if you pull their lower lid down, see those telangiectatic vessels coming across, pretty classic for acne rosacea. And well, the big trigger for this is Demodex. We're seeing a lot of press about Demodex, not because it's something new, it's always been around, but we're now recognizing it as a big player for not only, the collarettes that we used to think was staph blepharitis, well, that's Demodex. It's also a big trigger for patients with acne rosacea. There's two forms, there's a follicularum as well as the brevis form. Traditionally, we plucked eyelashes. You can actually just twist them. So if you grab it towards the base of the eyelash and then you twist, it backs itself out. All right, and as you continue to twist, you're going to see the second one's there. All right, and there's the second one. So we don't necessarily have to pluck the eyelashes. By twisting, and we'll recognize that they're there. So the pharmacological agent with the strongest evidence for efficacy for persistent facial erythema in rosacea is what? So which of these medications has the best evidence to get rid of the redness that patients get with rosacea? Right, continue to answer, but I'm going to show the responses here. And the correct answer is actually B, topical bromonidine. The topical bromonidine gel has got the best evidence to show reduce the erythema component to it. The downside to it is it's really expensive. It's upwards of $500, right? So it has the best evidence, but it's also the most expensive of them. So for rosacea, one of the best ways to avoid the triggers, but basically being alive is a trigger for rosacea. So patients with sunlight, spicy foods, heat, that type of stuff can all trigger them. I know there's a lot of information on this slide, but trying to get rid of either around the triggers or treating some of the potential triggering events like your Demodex. We now have Xdemvy, which is twice a day dosing for 6 weeks. Remember, the life cycle of Demodex is 6 weeks. Is now indicated for the treatment of Demodex. So again, Xdemvy, twice a day dosing for 6 weeks. Remember, you're not going to be able to necessarily go through your normal pharmacy for this. They're going to have to go through like BlinkRx or one of the kind of national things for, like, I think Walgreens might be on there, but it's not your Walgreens store. You have to go through their main one and then you send it to the store. Doxy and minocycline are effective for those kind of flushing issues. What they're doing is they're sublethal doses. In other words, we're not doing 100 milligrams twice a day. We're doing 50 milligrams. So Oracea, which is actually for acne rosacea, is 40 milligrams, but most of us prescribe 50 because it comes as a generic. You're sublethal for killing. What you're doing is actually shutting down the lipase activity, which is what the inflammatory component is actually causing that redness. You don't want to kill the bugs that are there because something else is going to come over and take over. What you want to do is shut down their lipase activity. So, 50 milligrams for a few weeks will help reduce that, lipase activity and decrease that inflammatory response. So topical bromonidine gel, the one that's called Mirvaso, I looked it up in Portland here, it was about $530. It does have the best evidence for it. The downside is the cost of it. Laser light sources are actually really good, particularly for the telangiectatic vessels. So if you have access to IPL, treating the telangiectatic stuff with IPL is actually really effective. Thought to not only kind of maybe change the bacteria, but also maybe potentially killing the Demodex as well. That may be a trigger. So other conditions that we might use the tetracyclines for, hordeola, meibomian gland dysfunction, recurrent corneal erosions. Your macrolides, this is including erythromycin and azithromycin. Really not using erythromycin for much anymore because there's lots of resistance. If you're using erythromycin ointment on someone's lids, you probably should be putting Vaseline jelly on there for the amount of work that it actually does. Azithromycin is probably the main one that we tend to remember from this group. Z-Pak, the best dosing regimen that's out there. 2 pills on the first day, then 1 pill for the next 4. It's commonly used for things like bronchitis and pneumonia. I don't prescribe doxy anymore for meibomian gland dysfunction. I'm exclusively azithromycin. there's kind of really three ways that you can do this. There was shown, one study showed that a single Z-Pack was better than a 30-day supply of doxy. I was traditionally doing kind of like 4 Z-Packs. So I actually prescribe 500 milligram tablets. I prescribe 12 of them. And patient would take it, say, like Monday, Tuesday, Wednesday. Then they would be off for the next 4 days. Then they'd take again Monday, Tuesday, Wednesday, be off for the next 4 days. And they do 4 cycles of that. For me, that was really effective. I had a gentleman come in who had like the worst glands I kind of ever saw. Like there was just nothing coming out of them. I put him on this treatment. He came back a month later, and I just basically went along with forceps and just squeezed everything out. It just kind of changed all that function that was there, and then everything came squishing out. The newest article that came out which was a few months ago, was that instead of doing that 500 milligram one, you do a single gram dose of azithromycin, and you do it basically 1 pill per week for 3 weeks. So you do a 1 pill on a Monday, the next Monday, and then the following Monday. And that was found to be better than a 6-week course of doxy with a lot less side effect profiles to it. So there's no the GI upset. There's a lot less compliance issues. I haven't tried that route yet, but that would be my next step, is I'll go that route. I haven't used doxy for my bone and gland dysfunction in years. I do think azithromycin is much better, and it's much better on their stomach and much better dosing regimens. Other things you might consider it for: internal hordeola, preceptals, and dacryocystitis. Chloramphenicol, not something would ever prescribe orally. It is actually being more used for like corneal surgeons, because it does a really good topical antibiotic for bugs that are there, because most of the bugs have never seen chloramphenicol. Just not something we would ever typically prescribe. It's available as an ointment or a drop. Clindamycin, it is indicated for MRSA. This one scares me a little bit because the fact that its side effect profile is pseudomembranous colitis, which effectively can kill the patient. So to me, I probably, if I was concerned about MRSA and I couldn't give Bactrim or I couldn't give doxy, then I don't know. I don't know if I'd be prescribing clindamycin. This one scares me a bit. Your inhibitors of nucleic acid synthesis, we're not going to talk about this group. This is your fluoroquinolone group. Now, topical-wise, they're perfectly fine. Oral-wise, there's really no indication in optometry to prescribe them. There's just not any indication unless you potentially have cat scratch fever, and we don't see that all that often. The only one that you kind of would want to be aware of is rifampin. Rifampin is not something you prescribe, but it is first-line treatment for anybody who has tuberculosis. It used to be isoniazid was first line. Now rifampin is. Isoniazid might be included in that mix, but rifampin is the #1 treatment for tuberculosis. And why you want to be aware of that is because patients will get discoloration of their bodily fluids. They'll become red-orange tinged. So you may have patients calling you freaking out that they're tearing blood. Well, that's because the rifampin is changing their bodily fluids. So be aware of that. Lots of side effect profiles to this group. So phototoxicity, CNS issues, GI upsets, tendinitis, changing blood sugar levels, pretty much everything is affected by this group. Your inhibitors of metabolism, this is your sulfa group. These are folic acid inhibitors, which bacteria need folic acid in order to replicate. When it shuts those down, then obviously the bacteria can't replicate. So sulfa and trimethoprim are in this group. We don't really use sulfas here that much in the US. It is used in other countries. Trimethoprim is really giving what that MRSA activity is from the trimethoprim. The combination of those two has a synergistic effect. So in other words, better than 2 medications alone, it has a synergistic ability to kind of shut down bacteria. It's a broad spectrum antibiotic. You have to make sure that patient doesn't have a self-allergy because you are giving them a self-medication. It's used for upper respiratory infections as well as things like prostatitis and so on, where you have to get a lot of medication into an area. So there's typically longer treatment times when you're using this medication. It is also considered first-line treatment for patients with a MRSA skin infection. It comes in 2 strengths. It comes in standard strength, which is 1 pill every 12 hours, or sorry, 2 pills every 12 hours. And it comes in double strength, which is 1 pill every 12 hours. The next question here is, say you have a patient that you want to put them on Bactrim or Septra. Which of the following medications the patient might be taking would be contraindicated to give them Bactra or Septra? So you want to prescribe Bactrim or Septra, but which of the medications a patient might be taking would be contraindicated? All right, continue to answer, but I'm going to show the responses here. And the correct answer is methotrexate. Methotrexate, which is kind of your gold standard for like rheumatoid arthritis and other autoimmune diseases, is also a folic acid inhibitor. So what could happen is you can actually kill your patient. So something we don't tend to want to do. It would probably have to be a little bit higher dose, but even still, it's a huge risk for patients because both of them inhibit folic acid, which then results in bone marrow suppression, and your patients could die from that. I've been giving this systemic antibiotic lecture for many years, and I actually didn't know this until a couple of years ago when we got a new EMR system. And when I was looking at the patient's medication, had methotrexate in it and had a big warning flag came up saying, do not prescribe Bactrim or Septra. Well, that's weird. Why not? Because the fact it can cause patients to die. There's actually a lot of contraindications to Bactrim or Septra. Like you can use it with certain blood pressure medications. You could use with atenolol, but you can't use it, say, with lisinopril. You can use it with certain antidepressant medications, but not other ones. So there is a lot of potential cross-reactivities, but just be aware, particularly for methotrexate, that if you do prescribe it, it could result in significant issues. So methotrexate is contraindicated because both of them are folic acid inhibitors. The other thing that's tend to be forgotten with this medication is it can actually result in kidney stones. So you want lots of fluids with this medication. You do not want your patient to be dehydrated on this medication. And another thing that's often overlooked in this one is also sun sensitizer as well. So much like Doxy is. So make sure if you're ever prescribing this one, no methotrexate, make sure you're telling them to drink lots of fluids. In addition to that, take sun protection as well. Your inhibitors of cell membrane function, there's really nothing that we would ever prescribe from this group. The one that you'd tend to know familiar with is basically isoniazid, not something you're prescribing. Strictly used for tuberculosis, so not really any indication for you to be prescribing these medications, but to be aware that patients might be taking these medications. And I believe that's it. So if you have any questions, you feel free to email me, but also I think we're going to do some question and answer right now too.
That was perfect timing. That was amazing.
Thanks. By the way, that's my email address. If you want a copy of my presentation or you want those articles related to, the minocycline and the neurology stuff, then feel free to email me. I'm happy to email them to you. I also pretty much have access to any article that exists on the planet. So if you ever need, kind of do a quick search on something, it's easy enough for me to do, and I can just send them to you in PDF files.
Perfect. That was amazing. That was a very clinically useful, relevant presentation.
Thank you.
I think I speak for everybody listening that was one of the best summaries I've heard of all of the oral.
Well, I mean, systemic antibiotics, I don't know anybody who would want to wake up at 7:30 in the morning to listen to systemic antibiotics. Like, I don't know if I would. So I try to make it clinically relevant because I do think it's really important for us to prescribe these medications and to do it in an appropriate manner. And I do think we get nervous by doing it. So to me, I'm a clinician, so I want to think about things what they're clinically relevant for me, that I would want someone to tell me what can I do and what conditions would I do it for.
It's much appreciated. So I can see some great comments coming in. So we're going to take some questions now. We've got a few minutes. So if you have any questions that you didn't put in the chat or the Q&A during the presentation, please feel free to put them in now. I'm going to get through as many as possible, but you also have Dr. Lonsberry's email address. So I'm going to go back. So some of these are go back to the beginning of the presentation.
Yep.
What probiotics do you use, if any, or do you just recommend yogurt despite no dairy products recommended with antibiotics?
Yeah, so I actually do yogurt, so I think that's the easiest one. So when I got my sty, I got amoxicillin, and I just bought the little containers, like the whatever they are, and it's just one container 2 hours after. That's why you don't want to take it at the same time, because it can actually interfere. The antibiotics will just basically kill the bacteria that's in the yogurt. So you want to do it 2 hours after. But patients can also do things like kombucha or whatever that they're considering probiotics. I don't necessarily know about the probiotic pills, whether or not they have the same ability. I would try to do things like have live cultures in them, like yogurt. So, and one container of yogurt has more than enough probiotics to start kind of regenerating that system. So that's what I typically recommend. So unless they're allergic to dairy or they don't really like yogurt, then you have to look for all other alternatives. But I would say yogurt's probably the best option for them.
Perfect. There was quite interest in that penicillin testing that you were mentioning early on.
Yep.
Is that typically covered by insurance?
I don't know about the answer about covered by insurance, but I probably would suspect it is. And you can actually go through the primary care physician to do it. I would highly suspect the primary care physician would be all about that. Because the fact that we know that this is a big deal, that they are recommending. Again, some of the recent articles are saying do direct challenges. I don't know about you, Jan, but if you had a penicillin allergy and you said, oh, well, I'm just going to direct challenge you again to see whether or not you're going to respond, I'd probably go, no, I think I'll pass, right? So that direct challenge philosophy doesn't make a lot of sense to me, but I do think because I lecture in this area and because I use Augmentin an awful lot for skin infections, we can eliminate this group. And because there was a program started in 2010 that the basically US government wanted 10 by 20. So they wanted 10 new antibiotics by 2020. So in the 10-year time period, they wanted 10 new groups of antibiotics. We got one in that entire 10-year time period, and it was specific for Clostridium infections in the gut. Nothing else new came out. They were just all revamps of what already exists. So for me, taking the penicillin group out, which is I spend a majority of time on, is a huge group of antibiotics, particularly for us, that we need to prescribe. So anybody comes with penicillin allergy, I asked them what symptoms they had, and I said, you really need to get penicillin testing done.
I think it's so relevant because so many say, oh, I heard that when I was a kid. I mean, myself, I'm here thinking about that myself. I'm like, oh, my next appointment. My mom said, oh, I think you had a reaction. I've been very
conscious. And it's interesting because people say that they have a penicillin allergy. Well, when did you ever get penicillin? You never took penicillin. You took amoxicillin or nafcillin or something. So when people say they have a penicillin allergy, I know they're trying to basically say the group, but no one's ever gotten really penicillin unless you had syphilis, which you get penicillin G or V for. You likely didn't take penicillin. So, and again, the information, I knew that the people were not as allergic as they think they are. The one that kind of was new for me was that people who've had penicillin allergies as kids, after 10 years, 80% of them grow out of it. That was new information for me. And to me, that kind of makes sense. We know that allergies are much more common in kids, and as our GI flora changes, our allergies change as well. So again, I think it's really important because most people would have the penicillin allergy as a kid. Now as adults, the likelihood is that they don't have it anymore.
I think that's great clinically and as parents. Like my son had an amoxicillin allergy when he was younger. So this is something I'll remember as he gets older too, that I don't want to burden him with that.
So Jan, if your son comes in now, he's 20 and has a stye, you're going to say, I'm going to direct challenge you. I'm going to give you amoxicillin and see what happens, right? You're not going to do that. But to get penicillin testing done, because also the concern with penicillin's allergies is that you're potentially eliminating the cephalosporins as well, right? And that's really just the first gens like Keflex and so on. The C-chlor and Omnicef are probably not going to cross-react. But again, that's another major group of really important skin infections. So to me, it's really important.
We're seeing some comments personally as a penicillin allergy, somebody who's had a penicillin allergy my whole life. Thank you for that last part, new information, and love it. So I think so many of us on here personally might take this information and on Monday might make a call and say, this is something for myself.
And it's obviously something you're not going to force them to do, but I kind of go through the stats with them, and I'll say, so you have penicillin allergy. I ask them so that's kind of from that article says, you need to find out what reaction, but if it happened 20 years ago, you don't remember. And if you're a kid, you don't remember, right? The ones that they would get concerned about is that there was a true anaphylactic response. There was either breathing issues or hives. Anything else, they're saying, do the direct challenge again. Well, again, anyone who's had that's not going to want to do that. But so I tell them, I said, what reaction did you have? And I tell them, typically after 10 years, 80% of people grow out of the penicillin allergy. I said, this is a really important group. And I kind of go through the resistance issues that are coming up. I said, I just recommend the next time you see your primary care physician to request penicillin testing done. And at that point, it should make them feel more comfortable too. So the other parts of this, Jen, that I probably didn't mention was that people who have penicillin allergies actually get subclinically treated because they're using other things that actually are probably not the best to be used. And then it actually tends to be actually increased cost to the healthcare system because they're worried about this penicillin stuff. So they're taking this whole group of antibiotics, which is probably the best to treat them with, and treating them with other things that are not effective, and they're not actually treating them properly. So that to me is another big part to this, is that if you say you have penicillin allergy, you actually probably need penicillin, but they have to use something else, which may not actually work as well.
That's fantastic information. That's something so usable. There was a great question that happened early on. This is something I know comes up a lot. What is your take on prescribing capsule versus tablet? I know this is a common question we all have when we pick from our drop-down menu. Is it capsule, tablet? Is there a difference?
There's not any difference. I just typically think that with the capsules, I personally don't like capsules because I don't like the capsule part to it. It kind of gives me some issues gut-wise. So I much prefer tablets to that. There's really not much any difference on potentially absorption and so on. It's just basically how the company wants to put that medication into you. I personally prefer tablets. If I ever see tablets, I prefer those over capsules, just because that's a personal preference. The ones that we tend to think about are different preparations. So Doxy comes in hyclate and monohydrate formations. It makes actually no difference. Once again, to the system, they work exactly the same. It's potentially that one might be a cost issue between the two of them, and the other one might be that you might be allergic to the one formulation. But once it gets in the system, they work exactly the same. So it makes no difference if you do the monohydrate or hyclate. We just typically write doxycycline, but it makes no difference which formulation it's in.
Perfect. And it looks like we have time for one last question, although a lot just rolled in. This is actually a very cool one. What are the top 3 antibiotics you would take into rural Alaska?
Augmentin would be my first on that one, just because of the dosing regimen and the fact that it's got such a broad spectrum scope to it. The other one would probably be Bactrim or Septra because of the concern for MRSA infections. And actually, in that case, I'll potentially consider doxy or minocycline because of the MRSA component to it. Those would be my big ones, honestly. I mean, I do love the whole cephalosporin group too. I'm just much more familiar with Augmentin. So Augmentin, absolutely. Then because I'm concerned if I'm more rural, potentially for MRSA infections, having Bactrim or Septra in that group as well. And then potentially something like minocycline or doxy again to kind of give potential MRSA and then other infectious stuff as well.
Actually, there was one more. I'm going to sneak one more in. What medications should alcohol be avoided with? If you know.
I don't know if there's one that specifically comes to mind that you really can't be taking with alcohol. I mean, any of them are going to kind of change the whole issue. And my concern would be is that how much alcohol, right? If the person actually having liver issues secondary to alcohol issues, then that's actually my bigger concern because it increases chance for more toxicity, right? So it's going to cause more problems to the liver because the liver is already compromised. So you can actually get increased dosages because the liver is not functioning as well to detox that medication. So you can get toxicity from that. That would probably be my bigger concern on that one, is that if people have alcohol intake, then is there potentially decreased functioning of the liver from that?
All right, we're back for round 2 of our afternoon. How are you, Dr. Lightizer?
I am great. How you doing?
I'm good. We've had a great weekend. You're our final presentation in our Woo You Oral Pharma weekend. So we're excited to have you finish off this amazing weekend and teach us even more. We've had such a great time and some wonderful feedback and just a great number of people who decide to spend their weekend with us, which is wonderful. So just a quick reminder, this is our last presentation and you will see, we'll go through the housekeeping slides again. At the end of this presentation, we will announce the final 2 winners of the Starbucks gift card. So make sure you don't leave just yet. So make sure you listen in for that. But let's begin. I know you have lots of information to share, so I want to get to your presentation. So welcome back to our last 2 hours of our Woo You Oral Pharmaceutical Weekend. I'm here with Dr. Nathan Lightizer with Oral Pharmaceuticals in Anterior Segment Disease. So it's still me, Dr. Jennifer Stewart. And it is my great pleasure again to introduce another wonderful speaker today. Born and raised in Bismarck, North Dakota, Dr. Nate Lightizer is a graduate of the Pacific University College of Optometry. Upon graduation, he completed a residency in family practice optometry with an emphasis in ocular disease through Northeastern State University, Oklahoma College of Optometry. He's since joined the faculty at the Oklahoma College of Optometry and serves as the Chief of Specialty Care Clinics and the Chief of Electrodiagnostics Clinic. In 2014, he founded and now heads the Dry Eye Clinic at the Continuing Education at the College of Optometry. In 2014, he was named the Director of Continuing Education as well as the Assistant Dean for Clinical Care Services. Starting in 2020, he was named Associate Dean of the NSU Oklahoma College of Optometry. He's a founding member and currently serves as president of the Intrepid Eye Society, which is a group of emerging thought leaders in optometry. He was named a member of PCON 250, a list of the top 250 optometrists in the country who practice progressively, provide innovative patient care, conduct optometric research, or excel in academia, and share what they have learned with other optometrists to advance the profession. He lectures nationally and internationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular disease. With that, welcome, and I'm going to turn it over to you.
Thanks, Jen. Appreciate it. There's my disclosures there. All of those relations have been mitigated. Make sure we take that step for the COPE approval process. So I guess I'm the closer in this oral pharmaceuticals weekend. I believe all 8 hours have been orals. Is that right, Jen?
That is correct.
Yep. So I guess I'm the closer, and I'm taking it home and tying it all together. So you guys have been extremely well educated on oral pharmaceuticals by Jim Finelli and Jim Timmons and Blair Lonsberry. So I'm going to do mostly cases and try to keep you guys as and entertained and educated as possible in oral pharmaceuticals in anterior segment disease. Like Jen said, I am at the Oklahoma College of Optometry in Tahlequah, Oklahoma. Hard to believe, been there for 15 years now, where I serve in a variety of roles, including the chief of our specialty care clinic. So, we see a tremendous amount of ocular disease through here in northeastern Oklahoma. We're in the counties, the 14 counties of northeast Oklahoma. We serve Cherokee Nation, as I'll talk about here in just a little bit. But again, my pleasure to be here. I want to thank Wu University for the invite to lecture with them once again here at Wu U for this oral pharmaceuticals weekend. We talked about my disclosures there. And if you've been to my lectures before, I like to poll the audience. I'm guessing Blair did this as well. So open up your phone and scan that QR code. When you scan that QR code, that will bring up my poll everywhere page. I want to make it very clear that this is optional. It is not required. You do not have to do this, but it's a nice, fun way to poll the audience. I used to hand out clickers at my lecture. Now we can do it with your phone. So open up your phone, open up a browser. So open up Safari or Google Chrome, whatever. And all you gotta do is open your camera and scan that QR code. And when you scan that QR code, that should bring up my poll everywhere page. This is a completely anonymous way to poll the audience. Nobody will know what you put. I won't even know what you put. Again, it's completely anonymous. There's no individual answers, but it's nice to see what the group think is. What percent are thinking A versus B versus C versus D. I'm going to poll you on what your favorite oral antibiotic is and what your favorite oral antiviral is. Again, we're talking oral pharmaceuticals for anterior segment disease. I'm guessing there's going to be a lot of review from what Jim and Blair covered as well, because again, we're in hour 7 and 8 for oral pharmaceuticals here. But again, open up your camera on your phone and scan that QR code. If you don't have a camera around you, you could just go to, and there, hold on, missed it. There's all right, perfect. I already got 83 of you that has responded there. Again, if you don't have a camera, you could just, on your computer, go to pollev.com/Nate Lightizer. If you type that into the browser, into the URL, that will open up my poll everywhere page. You don't have to sign up for anything. You don't have to download anything. So no signing up, no downloading, nothing like that. And again, you can scan the QR code. That's the easiest way to poll the audience. So I always have an intro question. Here's the the intro question. Woo you is which one of these to you? And obviously I gave you 4 answers there. And what's cool with this, and again, I want to emphasize again, this is not required. You will still get your CE credits, even if you don't do this. But again, you'll still get your CE credits. This is not required. It's optional. But what's cool is you can I hit a button here and you can see it gives you the responses and you can see what percentage of the group is thinking A versus B versus C versus D, et cetera, et cetera, et cetera. So again, thank you to Woo You for the invite, and let's move on. So our first case, I shuffled them around just a little bit to talk about this first case. So this first case was a case that I saw as a resident while on call here at the College of Optometry in Oklahoma. Again, I'm in Tahlequah, Oklahoma. It's about an hour to the east of Tulsa, an hour to the west of Fayetteville, Arkansas, again, tucked into the northeast corner of Oklahoma. Here in Green Country, the College of Optometry was put here in Tahlequah, Oklahoma back in 1979 because of Cherokee Nation. We are the official eye care provider for Cherokee Nation. We handle all of their eye care needs. We have 11 different locations scattered across Northeast Oklahoma. Again, 11 different separate locations. And we're in our own little bubble of socialized medicine. If you are any part Native American, whether you're Cherokee, Chickasaw, Choctaw, whatever it is, if you're any part Native American, you can come to our clinics and get your care at no cost. Whether you are full-blood Native American or whether you are 1/32nd Native American, if you can prove your ancestors were Native American, if you can prove that we're on something called the Dawes rolls, you can come get care at our clinic at no cost. So my point of telling you that is we see a lot of patients in our own little bubble of socialized medicine, and it's at no cost. And when our residents are on call, again, we have 6 residents at the College of Optometry in-house, and they handle call. They handle on-call, which starts at 5 p.m. and ends at 8 a.m. the next morning, or starts at 5 p.m. on a Friday and ends at 8 a.m. on a Monday. So our residents usually rotate weeks on call. So you're on call about 1 week every month or so as a resident. Well, when you eliminate the cost of going to the urgent care or going to the ER, when there is no cost, you see a lot of patients. On average, our residents see between about 15 to 20 patients per week while on call. I want you to imagine that your normal week, your 8 to 5, you're seeing your patients, but then add in 15 or so patients after hours on your regular week. Oh, your phone rings at 7:15 p.m. and you got to go see a patient. Oh, your phone rings at midnight. You got to go see a patient, or whenever it is. You see a lot of patients. So, and it's a great thing during your residency in terms of experience, and you see so much stuff. Foreign bodies, you get so comfortable with foreign body removal. But by the end of your residency, you are ready for on-call to be over because you're like, I want to take my life back in between the hours of 5 p.m. and 8 a.m. This was my last week of on-call as a resident back in June of 2010. And I'll never forget, it was Monday about 10 p.m. The phone rings. And when we get called by Cherokee Nation, the urgent care here in Tahlequah, we can't triage over the phone. It is, Dr. Nate, we've got a patient here, and we need you to come in and see them. Great. Our residents go in and they see them. So there's no triaging over the phone. There's no talking the urgent care doc or the ER doc through this. It is, you're going in to see the patient. So phone rings about 10 p.m. I go in and see this patient. They tell me we got a younger female patient here with a swollen eyelid. All right, I'll be in there in about 10 minutes to come see the patient. And I'll never forget when I walked in the room, the patient was sitting in the chair and she had a washcloth with an ice pack over her right eye. She was bent over just like this, kind of sitting there. And I called her name. And I remember that she looked up and she said, "Doctor, will you just stick a needle in this and drain whatever it is?" And I remember chuckling to myself going, I haven't even seen it yet because you still got it covered up here. But I'm like, no, I'm not going to stick a needle and drain whatever this is. So I said, come on with me. I took her down to the exam room and I see her and her eye looks like this. And this is the patient. This is a 23-year-old female. And this 23-year-old female has this swollen, red, painful right upper lid. Swollen, red, painful upper lid. And what's your first question going to be? Well, anytime you guys see patients with a red eye or a swollen eyelid or flashes and floaters or decreased vision, what's your first question? Or even it's a lump and bump on the eyelid, what's your first question going to be? How long has that been going on? How long has this been going on? Whether it's decreased vision, a red eye, or this significantly swollen. I mean, just look how swollen that is. And she said she was in 10 out of 10 pain. And that means something for me when it's coming to from a female. If it's from a male, we're just wusses. But from a female, she's in 10 out of 10 pain, significant redness, so swollen. And this started on Friday. So she said about Friday afternoon, I noticed that I could feel myself blinking. And I went, this is interesting. Remember, this is Monday evening. I'm now doing case history about 10:30 at night. 10:30 at night on a Monday evening. This started on Friday. And she just said, I could start to feel myself blinking. I could feel the presence of a blink. And over the course of Friday and Saturday and Sunday, it got more red and more swollen and more tender, and she just couldn't take it anymore. And finally, she came in to be seen. This was so swollen, she could barely open her eye whatsoever. And I go back to she could just feel kind of herself blinking. About 5 years ago, I was in Utah doing a laser workshop with a group of doctors in Utah. And I remember during the lab, I started, when you're busy, you're not thinking while you're blinking. You don't think to yourself, blink, 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 and you don't feel any pain or discomfort while you blink. And I remember during that laser workshop, I could start to feel a little bit of tenderness while I was blinking. I'm like, this is interesting. And at the end of the workshop, I walk into the bathroom to take a look in the mirror, and sure enough, I've got a little redness, the start of a little swelling. And if I pushed on it, there was a little bit of tenderness. It was the very early starts of a hordeolum and associated preseptal cellulitis. So when she told me that it resonated with her, that she could feel herself blinking on Friday, I went, sure enough, I know what that feels like. This is, again, before this happened to me, but I now can resonate with that. I'm going, yeah, I know what that feels like. And again, over the course of Friday, Saturday, into Sunday, this got worse and worse and worse, more swollen, more red, more tender. She's in 10 out of 10 pain. This is to the point where she cannot open the eye in the right eye. This is so swollen that when she's talking to me, she's just like this. I cannot see the globe. The left eye is uninvolved. The left eye is totally fine. So this was so swollen and so edematous that I couldn't see the globe. However, if I said, okay, go open both eyes as much as you can and tip your head up like this, I could just see a sliver of the globe, just enough to see just a little bit of the globe, and it was enough to check her visual acuity. She was 20/30 in this right eye, 20/30 in the right eye, and 20/20 in the uninvolved left eye. Left eye looked perfect, normal, everything was intact. Right eye, she eked out the 20/30 line. So vision was actually relatively good, but again, I couldn't do this and open her up. There was no way I could open up her eye whatsoever, but if she opened both eyes as wide as she could and tipped her head back, she could just look through that sliver of an opening, and she squeaked out the 20/30 line. It was enough to check her pupils. Swinging flashlight, going back and forth and back and forth. Her pupils were normal. I could test her EOM. She could look up, and she could look down, and she could look left, and she could look to the right. She had full range of EOMs, and there was minimal to no pain on EOMs as well. So vision was pretty good. Pupils were normal. EOMs were normal. It did not appear that she was proptotic at all, which was very, very good. Before I got in there, the triage nurse, they call anything eye related, anything in this area, they don't do a whole lot. They just call the on-call optometry resident, and we'll come in and take a look at that. But they do a few things. They checked her temperature. It was 98 point whatever degrees. She had a normal temperature with no fever. Excellent. I'm very happy about that. So she's got no temperature. She's got her EOMs are normal, minimal to no pain in eye movement. She appears that she can look in all directions. Pupils are normal, not proptotic. Looks great at this point in time. And ultimately, the globe looked uninvolved. As much, I really couldn't examine much of the globe, but from what I can see, the globe looked uninvolved at this point in time, which is certainly a good thing. So my question for you guys is, based on the clinical history and appearance, what is your diagnosis in this 23-year-old female? Is it orbital cellulitis, preseptal cellulitis, a lid abscess, a bug bite, dacryocystitis, or dacryoadenitis? And again, I want to emphasize this is not required to ask. This is just kind of a fun thing to do. And if you missed this at the start, there's the QR code on the top right. The website on the top left. You don't have to download anything. You don't have to sign up for anything. Again, this is not required. It's completely anonymous. Just a fun way to poll the audience, to kind of see which way the group is leaning. We've got a 23-year-old female, again, a swollen eyelid. This started on Friday, got worse into Saturday, worse into Sunday, worse into Monday. She's in 10 out of 10 pain, really can't open the eye whatsoever. But the globe does appear to be uninvolved at this point. So in this 23-year-old female, what do you guys think this is? Let's take a look here, and we'll see the about 90 of you that responded. And I'm guessing we have a strong leaning, absolutely, towards a preseptal cellulitis. 90% of you think this is a preseptal cellulitis, and I would completely agree on that. This looks like a severe preseptal cellulitis. You know, why is this not an orbital cellulitis? Let me go back. Why is this not an orbital cellulitis? Well, I think we've done most of the things to rule out orbital cellulitis. There is no fever. Her temperature is normal, no fever. She doesn't appear to be proptotic. Now, I didn't bust out the Hertel exophthalmometer because, again, all the swelling, but just based on a gross observation, she didn't appear to be proptotic. Her pupils were normal. She appeared to have full range of EOMs with minimal to no pain on EOMs. And oh, by the way, remember that triage nurse, and there's a doctor there involved as well, that before I got in, they checked her temperature. They were so freaked out by this, of how swollen this was. They actually ordered a CT scan before I got in there. So when I actually got there, a CT had already been ordered and was done. So I had a CT scan report showing me that there was no orbital involvement, which I think was very, thank you. I appreciate that. So the CT was normal. So I felt pretty comfortable that this wasn't an orbital cellulitis, lid abscess. That's kind of a diagnosis of exclusion, a bug bite. You know, we actually asked, I asked her, you know, were you bitten by anything like this? And she denied being bitten by a bug or anything like that. I couldn't see any focal red spots or bug bites there. We have in Northeast Oklahoma, in our neck of the woods, we have what are called brown recluse spiders, fiddlebacks. And I had a patient, this is a number of years ago, that was in just for a general diabetic exam. And right in the middle of her forehead, low forehead, she had this black necrotic tissue. It was about the size of a dime. And I remember asking her about it, and she goes, yeah, you know, that just appeared one day. I mean, this has been going on for a while, and they think I got bitten by a fiddleback, by a brown recluse spider while I was sleeping there. So I've had patients that have had spider bites. She didn't remember bitten by anything. I don't recall that. Didn't appear to be any focal spot where something that had bit her. So I didn't think it was a bug bite. Dacryocystitis. Why is this not dacryocystitis? Location, location, location. This is not in the right location. Obviously, dacryocystitis would be down here, inferior nasal, that infection of the lacrimal sac. I'll show you a picture. I'm not going to go through a case of that, but I'll show you a picture of a severe case of dacryocystitis here in a few minutes there. So it's not dacryocystitis. And dacryoadenitis, an infection or inflammation of the lacrimal gland, kind of upper, outer. That's more of a zebra. You know, could it be that? I suppose it could, but think horses before zebras. We always train our students and residents, horses before zebras. It can cause like an S-shaped ptosis, maybe really a diagnosis of exclusion there. So I completely agree with the 92% of you that this looks like a preseptal cellulitis. So here's my next question for you. You know, so what would you start the patient on? What would you start this patient on? Augmentin, amoxicillin clavulanate, 500 milligrams 3 times a day, or 875 twice a day. Bactrim, double strength. Cephalexin or Keflex, a first generation cephalosporin, 500 milligrams 3 or 4 times a day. Azithromycin, a Z-Pak, doxycycline, 100 milligrams twice a day, a topical antibiotic like Vigamox, moxifloxacin, or something else. Polling is open, and there are multiple correct answers here. There's a lot of correct answers. I'm really just polling the audience. If you have a case tomorrow of a significant preseptal cellulitis, what would be your go-to oral antibiotic? What would be your go-to oral antibiotic in this case of a, this is a pretty significant one. If you said, you know what, Nate, I'm not comfortable treating this one, I would maybe send that out, but I think that's fine. I think the vast majority of you would be comfortable treating this as a severe preseptal cellulitis because we've ruled out orbital. There is no fever. They are not proptotic. The pupils are normal. Heck, the CT that was like a luxury item. In this one, the CT was normal as well. So again, let's see what your guys' oral antibiotic of choices. And again, I completely agree with this. The number one answer is a penicillin augmentin, amoxicillin, clavulanic acid, 500 milligrams 3 times a day, or 875 twice a day. I love that answer. It's your number one. Clearly, it's my number one as well. Keflex, the number 2, first generation cephalosporin, cephalexin, 500 milligrams 3 or 4 times a day. That's the number 2 answer. Azithromycin is the number 3 answer, and Bactrim would be the number 4 answer. I think all of those are probably correct. I'm going to have a little bit of a caveat with azithromycin here in just a little bit for that. Maybe not. My number 1 would be amoxicillin clavulanic acid. My number 2 would be cephalexin. My number 3 would probably be Bactrim in any particular order. I may shy away from azithromycin in this particular case. So let's go back to the case. I changed it up just a little bit because I wanted you to answer this question. I wanted you to answer what oral antibiotic you would put this on, and I completely agree with your choice. I think there's a lot of correct answers, but augmentin would have been my number 1. When I saw her on Monday evening, and when did I see her? Monday evening about 10 o'clock, about 10:30 at night, and this has been going on since Friday. This actually got so bad over Friday, Saturday, and Sunday, she went to a different, more rural ER in Northeast Oklahoma, not the one where we have optometry residents on call, but there was no eye care provider. So she went to a different ER and saw an ER physician, and on Sunday night. So on Sunday night, she sought care for this by an ER physician. Again, not an optometrist, not an ophthalmologist, saw an ER physician who diagnosed her with a significant eyelid infection and started her on Bactrim. So on Sunday early Sunday evening, she had been started on Bactrim, and he was so freaked out about this. This was so swollen and painful that he gave her a shot of Rocephin, an intramuscular cephalosporin, in the buttocks. So on Sunday evening, I want you to remember that she was started on Bactrim, an oral antibiotic, combination of sulfamethoxazole and trimethoprim. She was started on Bactrim Sunday evening, and she was given a shot of an intramuscular cephalosporin on that Sunday. Fast forward to Monday. Before I got in on Monday, what did the triage nurse and the triage doctor do? They checked her temperature. Thank you very much. They ordered a CT scan. I appreciate it. Awesome. Making me feel better that this is not an orbital cellulitis. They also were so freaked out about this, they gave her another shot of intramuscular cephalosporin in the buttocks. Number 2. So she had number 1 on Sunday night and number 2 on Monday night as well. And she was started on Bactrim, as you recall, on Sunday. So by the time that I see her on Monday evening, what am I going to do? She's already been on an oral antibiotic for about 24 hours. So oral for 24 hours. She's had 2 shots of intramuscular cephalosporin in the buttocks. So what am I going to do at this point? I'm basically going to let time do its thing. I really said you're already on an oral antibiotic, the one that, maybe not the one I would have started you on. I probably would have started you on augmentin, but I'm totally comfortable with Bactrim. You've had 2 shots of a cephalosporin into the buttocks. I gave her some Tylenol 3, just a handful of tablets of Tylenol 3, because that's what we had on formulary at the time, and said, let's just give this some time for the antibiotics to kick in. That's what I did at this point. And I said, we'll see you back tomorrow. I'm going to see you daily to make sure that we have resolution. I'm expecting the antibiotics to kick in about 48 to 72 hours, 36 to 72 hours. So let's give these antibiotics some time to kick in. Great. I'll see you tomorrow. Here's your Tylenol 3, your codeine, and just kind of get through the pain. These antibiotics should be kicking in anytime now. So on late Tuesday afternoon, about 4 o'clock Tuesday afternoon, I scheduled it late in the day to give as many hours as possible for the antibiotics to kick in. On Tuesday afternoon, she said, it's no worse. That's the good news. But the bad news is it's no better. I'm still in 10 out of 10 pain. It's still, it hurts so bad. It's still red, swollen. She really couldn't open her eye whatsoever. And on Tuesday afternoon, I'm going, okay. So it's been about 48 hours now on oral antibiotics, on Bactrim. 48 hours since the first shot of intramuscular cephalosporin. I'm like, golly, this should be getting better. I still don't think it's an orbital cellulitis. Why is that? She is not systemically unwell. Like if you ignore this spot right here, other than that, she's fine. There's no fever. She gets her temperature is normal. She still is not proptotic. Her vision's still hanging in there. Pupils are still good. UMs are still full. So I'm still not concerned about an orbital cellulitis, but I'm like, oh, darn it. Why isn't this getting any better at this point in time? So I said, let's give it one more day. On Wednesday afternoon, I said, let's come back Wednesday afternoon at our surgery clinic, because if this is not better by Wednesday afternoon, and I'm not saying completely healed, but if we're not moving in the right direction by Wednesday afternoon, now we need to reconsider our diagnosis. Is this something else like an eyelid abscess or something like that? So let's come back Wednesday afternoon. Wednesday afternoon, she comes in, and it's good news. It's no worse, but the bad news is it's no better. It's exactly the same on Wednesday late afternoon that it was on Monday evening. It's no better. It has shown no clinical improvement at this point in time. So I brought our surgeon in and I said, what do you think? I thought this was a preseptal cellulitis. It's been treated with 2 shots of intramuscular cephalosporin. She's been on Bactrim for almost 72 hours now, and we are showing no signs of clinical improvement. Nothing at this point. It's not worsening, but it's not showing any signs of improvement. I still don't think it's orbital cellulitis for all of the reasons that we have outlined. So I said, what do you think? Does this need to be drained? And on my last day of residency in 2010, our surgeon, he agreed, and he said, yep, I think this is an eyelid abscess because of the history, because we've been on antibiotics for 72 hours and injections and showing no clinical improvements. I'm going to go in there and I'm going to drain what likely is this eyelid abscess. So again, on my last day of residency, I got to assist our surgeon in draining this eyelid abscess. And I will tell you, it's a case I will never forget. It's a procedure that I will never forget. Obviously, we cleaned this up. We prepped it, alcohol swab and betadine. And when he stuck that needle into the area to numb her up, to inject her locally with lidocaine, with epinephrine, when he stuck that needle in there, she screamed unlike anything I have ever heard before. It was unbelievable. This tissue is obviously infected. It is swollen. And when you get swelling, you've got tissue edema. And when you have edema, you have hypoxia. And when you have hypoxia, you have less blood flow. The tissue becomes more acidotic. And when the tissue becomes more acidotic, it takes longer for anesthetic to kick in. So again, the swelling, edema leads to inflammation. Inflammation leads to hypoxia. Hypoxia leads to lack of blood flow. This leads to the tissue becoming acidotic. It doesn't take up anesthetic as well. It took close to 10 minutes to get her numb. Again, when he stuck that needle, can you imagine sticking a needle in this infected, inflamed tissue? Finally got her numb. Finally, she's numb, and he makes an incision into the abscess. And what happens, guys, when somebody makes an incision into an abscess, what happens? It's so full of this pus and necrotic tissue. When he made the incision into that abscess, this thing just erupts and actually came and hit him right in the head. There's some that just skimmed right off the top of his head. I'm kidding. I'm joking. Just trying to wake you up there on a Sunday. Totally joking. But when you make incisions into these abscesses, they can ooze. And this ooze to some degree, yep, it's got all this pus coming out, and he pushed on it and drained all of this, got all of this stuff out. and started picking out pockets of tissue, and all this necrotic tissue came out as well. By the way, he made a little horizontal incision, tuck it right in the eyelid crease, right in the eyelid, little horizontal incision, and drained this eyelid abscess. Once he got all of this stuff out, he flushed it full of betadine. I thought that was very interesting. Is took some 5% ophthalmic betadine and squirted it inside the wound just for betadine to contact anything that was still in there, to kill anything that was in there. Flushed all of the betadine out. Flush, 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 flush with sterile saline. He tucked what's called iodofoam gauze. It's basically betadine soaked gauze. He tucked it inside the wound, covered this with ointment, just kind of put a bunch of ointment on there, patched her up, and we cultured this, obviously. Everything that the stuff that came out, we cultured it, we cultured it, and we switched her antibiotics. We took her off of Bactrim and put her on your favorite oral antibiotic and my favorite oral antibiotic. And I know Dr. Blair covered this as well. Dr. Blair's favorite oral antibiotic, which is Augmentin, amoxicillin and clavulanic acid. We switched her to kind of a more broad spectrum oral antibiotic, switched her to Augmentin on that Wednesday, cultured this up, again, ointment, patched her up, and said, we'll see you back on Friday. If any changes before then, let us know. But this abscess has been drained, and now we just need to let the body heal at this point in time. On Friday, she comes in with a smile on her face for the first time. She comes in smiling, and she goes, I can just feel it's better. I can't see it because she's patched up. But she goes, I can just feel it's better. The pain has been subsiding. I bet the redness is going to be better. The swelling is better. She goes, I can just feel that this is better. And we took the patch off, and sure enough, the redness is better. The swelling is better. Pulled the iodofoam gauze. That was kind of a surreal moment, pulling this gauze right out of her eyelid. Because again, he took some iodofoam gauze, betadine-soaked gauze in there, pulled all of that out, kind of flushed it, cleaned it up, everything like that. And the culture was not back yet. So culture was not back. So on Friday, we just said, yep, okay, good. We applied a little thin film of ointment here. We did not patch her up. All was good. It's healing. It's moving in the right direction. You know it. We know it because the redness is getting better. The swelling is getting better. The pain is getting better. She can now open her eye much better, which is awesome at this point. We said, come back on Monday. Okay, come back on Monday afternoon, and we'll see how this looks. On Monday afternoon, she walked in with the biggest smile on her face, and this thing was 90% healed at that point. I mean, the redness was almost gone. The swelling was much better. Her pain was gone on that Monday, and she was just doing better and better. On Monday, the culture was back. We got the culture back on Monday morning, and what did it grow is my question to you. This 23-year-old female that had a right upper eyelid abscess. What do you think this grew? I'll give you a couple of seconds to think about that. Take a sip of my water. What did this grow? And the answer is MRSA. This was a MRSA eyelid abscess in a healthy 23-year-old female. And how she got a MRSA eyelid abscess, I have no idea. She is not a healthcare worker. She doesn't work in a nursing home. Again, she's not a nurse that's been around somebody that had MRSA. She's never had a MRSA infection before. Our surgeon's best guess was that this had somehow come from maybe the nostrils, the nasal cavity. There are some individuals that harbor a MRSA population in their nasal cavities, their nostrils. He actually had her swab an ointment called mupirocin or Bactroban. It's actually made for the skin. It's not an ophthalmic preparation, but he actually had her swab that in her nostrils just to eliminate any MRSA population. So on that Monday, when the culture came back MRSA, we took her off of Augmentin and we switched her to your oral antibiotic of choice for MRSA. And I'd ask you, what is your oral antibiotic of choice for MRSA? I'm sure one of the three speakers covered this before, and your oral antibiotic of choice for MRSA is going to likely be Bactrim. The combination of sulfamethoxazole and trimethoprim. That is my oral of choice for MRSA. So on Monday, we switched her back to Bactrim. She was on it first. It wasn't doing anything. And the question really is why was this not doing anything? The answer is this is an abscess. This is an abscess. And what is the treatment of choice for an abscess, whether it's in the eyelid or whether it's on some other part of the body, the treatment of choice for an abscess is drainage. Yeah, the treatment of choice is drainage, and the body kind of walls off, which is a good thing with an abscess. The body has walled off this infection. That is a good thing. It prevents it from spreading. It localizes this, this infection to one area. That's the good news. The bad news is it really prevents the antibiotics from getting where they need to be, and that's why the treatment of choice for an abscess is ultimately drainage. So again, that ultimately happened in this case. We had her on Bactrim, and this resolved nicely. So go way back to the start of this case. Remember when I walked in on Monday evening, about 10 o'clock, 10:15 in the evening? I'm on the on-call resident. I'm in my last week of on-call. Can't wait to get rid of this on-call phone. What was the first thing that the patient said to me? Doctor, will you just stick a needle in this and drain whatever this was? She was right, wasn't she? So the take-home message is always listen to your patients. They always know best. They always know what's best for them. So, all right, we are moving on from case number 1. That was an eyelid abscess that was ultimately treated with drainage, but it walked us through our oral antibiotic paradigm. So it also walked us through of how do you differentiate a preseptal from an orbital cellulitis. And again, we've talked about this through the case. Preseptal cellulitis, they can have significant swelling. This was significant swelling, but yet it was a preseptal cellulitis. Why is that? Because her pupils were normal. She had a full range of EOMs, minimal to no pain on EOM. She was not proptotic. There was no fever. The CT scan showed no orbital involvement. If you ever have a case that looks like this, or it looks like, I'm going to go ahead here a few slides, I'll come back to, or it looks like this, a case of a severe dacryocystitis. And both of these cases, again, this is obviously right in the right location of a severe dacryocystitis. You need to check pupils. You need to check EOMs. You need to check, are they proptotic, things like that. And if you ever have a case like this, or like the other one, the dacryocystitis, and their pupils are involved, or they're proptotic, or their EOMs are restricted, or they have a fever, and I'm sure Blair talked about the cutoff for fever, then you got to start to worry about orbital cellulitis. So the differentials, again, we talked about all of these. The CT scan was certainly helpful in this particular case. So here is my oral antibiotic paradigm. And I know Blair just spent an hour and a half talking about this, so I'm not going to spend a great deal of time on this because he's covered this. Jim Timmons has covered this. So I'm just going to spend a few minutes on this. This is my oral antibiotic paradigm. When I'm thinking of, okay, I've got a patient that looks like this, or I've got a patient that looks, like this. And again, both of these are severe cases. They don't have to be this severe. Maybe they're mild. Maybe they're mild to moderate. But anytime I have cases that look like that, this is the oral antibiotic paradigm that I think of. Here's your 5 main categories of oral antibiotics, and maybe the most common medication in each category directly beneath it. You've got the penicillins, you've got the cephalosporins, you've got the macrolides, you've got the fluoroquinolones, and you've got the sulfa medications. Now, those are your 5 main categories of oral antibiotics. And, there's one category that's missing on here, and that would be the tetracyclines. Don't forget about the tetracyclines, things like tetracycline, but more likely doxycycline or minocycline. Certainly you can prescribe those as oral antibiotics, but as optometrists, we more often, not always, but we more often use them as what? As oral anti-inflammatories. We more often use doxycycline at 50 milligrams once or twice a day, which is sublethal. It's below the threshold of killing bacteria. It's just inhibiting those lipases. And we're using that for rosacea, acne rosacea, ocular rosacea, meibomian gland dysfunction, et cetera, et cetera, et cetera. So again, I know Blair talked about that, and I'm not going to talk on that because I'm going to talk on killing bacteria. And these are my 5 main categories that I think of when I need to knock out an infection. I need to get this infection gone. And again, that'd be your penicillins, your cephalosporins, your macrolides, your fluoroquinolones, and your sulfas. I bet Blair covered this slide as well, the Infectious Disease Society of America. The big key point on this one is 5 to 7 days. To me, it's 7 days. It used to be longer than that, but 7 days is the sweet spot for how long I'm going to prescribe an oral antibiotic for an adult. If it's a kiddo, we may go longer. We may go 10 to 14 days. But for an adult, I'm going to do about 7 days based on the guidance of the Infectious Disease Society of America. 5 days doesn't seem quite long enough to me. Maybe for a Z-Pack or a tri-pack, which is only 3 days, but 7 days is my sweet spot. We should not be prescribing Augmentin or Keflex for 14 days or longer than that. You're just giving bacteria the opportunity to have resistance. So 7 days is basically the middle of my road. Rarely I will go longer, usually not. 7 days is the sweet spot. So the other kind of pearl on this one is, and why isn't this opening here? Let's see. I want to make sure that these slides open. Oh, hold on just a second here. There we go. The question on this one is, what is the best drug for MRSA? And I show you this question, what the best, I'm sure this has been covered already. Your absolute best drug for MRSA. If one of your loved ones had a life-threatening MRSA infection or a sight-threatening MRSA corneal ulcer, something severe, whether it was vision or systemically, and they knew it was MRSA related, what's the absolute best drug for this? And the answer is vancomycin. Again, I'm sure this has been covered. Vancomycin is number one. Trimethoprim is right up there as well. So those are all correct answers, vancomycin and trimethoprim. 98% of you, you're absolutely correct. That is the best drug for MRSA. If my loved one had a sight-threatening or a vision-threatening illness, I would want vancomycin, okay? We'll come back to that in just a second. So the ARMOR data, the 2015 Antimicrobial Resistance Monitoring in Ocular Microorganisms. And again, I'm guessing one of your speakers has already covered this, so I'm going to go through this very quickly. Basically, they took all of these bugs and all of these drugs and said, how susceptible are the bugs to the drugs? How susceptible are these bugs? Will the drugs kill them? Or is there resistance to that? And you can see here for trimethoprim. Trimethoprim kicks gram-positive butt. Trimethoprim is a wonderful medication for gram-positive. It has a 97% kill rate against regular staph, a 93% kill rate against MRSA. That is awesome. Trimethoprim is awesome for gram-positive. And what's trimethoprim in? Polytrim, Bactrim. It's one of the reasons I'm such a big fan of Polytrim as an antibiotic, because it's got a great gram-positive trimethoprim and a great gram-negative polymyxin B. So there's trimethoprim, there's clindamycin, azithromycin, your levofloxacin. One of the reasons why I'm not huge on azithromycin is because of this data. Azithromycin is absolutely not indicated for MRSA, but even for regular staph, based on this data, only about 57% kill rate against regular staph. Your floxacins, we're all used to the floxacins. Those are wonderful antibiotics. We use them all the time topically. We don't use them that often orally, as we'll go through here in just a second, but they're great, not for MRSA. They only have about a 1 in 4 kill rate for MRSA. Only about 24% are susceptible. It's about 76% are not. You're based on the 2015 data. Here was your best for MRSA and your best for Pseudomonas. I'll take the right column first. The good news was pretty much everything was working for Pseudomonas. When we're treating a corneal ulcer, which again, we're talking orals, and we don't usually use orals for corneal stuff. There are exceptions to that. But when you're treating Pseudomonas, a corneal ulcer with drops, pretty much everything's working, whether it's a floxacin 3rd generation, a floxacin 4th generation, tobramycin, Polytrim, it's all working. That's the good news. MRSA, vancomycin, what's 100% in medicine? Nothing's 100% in medicine except vancomycin in this study. Trimethoprim is number 2. Of note, there wasn't a big enough N number to register, but besafloxacin, which you guys know as Besavance, is great against gram-positive, including MRSA. Now, it's not available as an oral. Besafloxacin, Besavance is not available as an oral. It's only as a drop. But if you're ever dealing with a MRSA conjunctivitis or a MRSA corneal ulcer and you can't get fortified vancomycin, your next best choice for an eye drop is Besavance. Besafloxacin has an amazing kill rate against MRSA. After that, it would be Polytrim, trimethoprim. From a drop perspective, from an oral perspective, that is why Bactrim, which has trimethoprim in it, is my #1 oral of choice for MRSA. They updated the data in 2018. You take a look at the 2018 data, and I'll give you a couple of seconds to digest this. And you look at all of these antibiotics. Trimethoprim kicks gram-positive butt. Awesome. Still about a 90% kill rate. It is why trimethoprim is my #1 oral for MRSA. Clindamycin, it may be my #2 or #3, depending on the case. Clindamycin, there are some issues with clindamycin, GI stuff, things like that, but it still works about 70% of the time for MRSA. Vancomycin, again, your #1, but vancomycin orally is just not readily available or usable. So vancomycin is IV. You've got IV Vanco or compounded Vanco drops, but orally really not readily available or usable. That's why we're going to trimethoprim is our #1 oral. Again, your floxacins. I'll call your attention to the floxacins. Awesome antibiotics, but not for MRSA. They are not the #1 choice for MRSA unless we're talking about besafloxacin, which is kind of a special fluoroquinolone. It's a chlorofluoroquinolone. It's not on here right now, but your floxacin's great, except against MRSA. Once again, your azithromycin, only about 60% kill rate for regular staph. 60%. It's terrible for MRSA, 60% for regular staph. Again, everything's pretty much working against Pseudomonas and strep pneumo. That looks great. And again, if I had to order, based on the 2018 data, your MRSA and your Pseudomonas. Again, everything's working against Pseudomonas. You got a variety of options, whether they're 4th generation, 3rd generation fluoroquinolones, tobramycin, or polymyxin B, which is in Polytrim. It's one of the reasons I love Polytrim. Everything's working darn well against Pseudomonas when we're treating on the ocular surface with eye drops. When it comes to the eyelids, again, you're much more likely dealing with gram-positive. Most of the bugs on the eyelids are gram-positive, and you take a look here, and again, it's vancomycin. All right, I'm not going to use that as an oral. Then it's trimethoprim. That's why Bactrim, the combination of trimethoprim and sulfamethoxazole is my #1. Clindamycin would be my #2 or #3. And then after that, they're not great options. Of note that was not in this study, why I would put it in there, would be doxycycline. Doxycycline 100 milligrams twice a day. 100 milligrams twice a day has shown effectiveness against MRSA. So I still would have trimethoprim up there first, but after that, doxy and clindamycin are my #2 and #3. I logged on at the end of Blair's presentation. It was a great question. If you're practicing somewhere, they said rural Alaska, what would be your top 3 oral antibiotics that you would want? And my #1 would be Augmentin, amoxicillin, and clavulanic acid. That'd be my #1. My #2 would be Bactrim, and my #3 would be doxycycline. Those would be my 3 that I would want. Why? I want my main oral antibiotic. I want my amoxicillin, clavulanic acid. I'd want my Augmentin. I would want something effective against MRSA, and that would be Bactrim. And that's my #1. But what if they have a sulfa allergy? And this kind of getting to this, my last slide on oral antibiotics here. All right, you got Bactrim, but what if they have a MRSA infection and they're allergic to sulfa? That's why I would have doxycycline in there as well for a couple of reasons. #1, I think doxy has antibiotic, but also anti-inflammatory properties. So I'd want that mixed in. But if I had a MRSA and they were allergic to sulfa, then I'd have a backup option or doxycycline. So my answer would have been very similar. I think that's what Blair answered as well, would be Augmentin, would be Bactrim, and would be doxycycline would be my top 3 there. So finishing up on my oral antibiotic paradigm as you take a look at this. The penicillins, it's your #1, it's my #1. That is your really go-to. It's your do-everything drug, and it works for almost everything. There's 2 reasons why I would not go to the penicillins, and you guys are familiar with these. What 2 reasons would you not go to Augmentin, amoxicillin, clavulanic acid? And it would be for MRSA. I would not go to it for MRSA. We have better options than amoxicillin for MRSA. So if I knew I was dealing with or suspected I was dealing with MRSA, would be #1. or if they're truly allergic to a penicillin. And I'm sure I heard Blair talking about allergies, so I won't get into that for repetition reasons. But those are the two reasons why I would not go to my number one augmentin, would be if I'm dealing with MRSA, or if they're truly allergic to the penicillins. Other than that, that's your do everything. Youngsters, geriatric patients, gram positive, gram negative, it works. Pregnancy friendly, it works. That's your do everything drug. Your cephalosporins, your Keflex. This is kind of a cousin to the penicillins. There's different generations of cephalosporins. I know Blair covered that. These are great medications. Your cephalexin, 500 milligrams, 3 or 4 times a day, amazing soft tissue penetration. So you could certainly go to that. I just think that the penicillins are a little bit better than the cephalosporins. But if they have a true penicillin allergy, you could consider the cephalosporins. But remember about that cross reactivity. And there's variable literature on the cross reactivity of that. I know that's been covered as well. The macrolides, your azithromycin, clarithromycin, erythromycin, your Z-Pak is going to be your main one. Again, go back to the ARMOR data. How well is azithromycin working on regular staph? You've got a 60% chance. How well is it working for MRSA? You've got a 6% chance. I don't know if I want to take a 60% chance that a Z-Pak is going to work for this. So this is pretty low on my list. Penicillins are 1. Cephalosporins are probably right in there. Bactrim is in there. Doxycycline's probably even in there as well, but unless there's any contraindications to doxycycline, I'm going to have to go a long ways down my list until I get to azithromycin. So, because of this reason, among other things, I may use it. It does have some anti-inflammatory effects, as we've talked about. But I tend to go a long way down my list before I get to the macrolides. The fluoroquinolones, again, I bet this has been covered as well. I use a ton of fluoroquinolones topically, not orally. It's very rare that I use an oral fluoroquinolone like Levaquin or Cipro. These are not quite as pregnancy friendly as the first 3. They're better for gram negative, but they will work for gram positive. And they're contraindicated in people under the age of 18 and over the age of 65. I'm sure somebody has covered this already, the tendinitis and tendon ruptures. I just don't want to have to deal with the tendinitis and tendon ruptures. They're at risk of that from your oral fluoroquinolones. It's a long way down my list before I get to the oral fluoroquinolones. And lastly is your sulfa, your Bactrims, sulfamethoxazole and trimethoprim. That's your Bactrim double strength. This is my oral of choice for MRSA. For MRSA, if they have a sulfa allergy and I think I have MRSA and I can't go to that, then I would consider doxycycline or clindamycin as well. So I'm going to finish with that in terms of the oral antibiotics there. Again, I showed this picture already. Prescribing these for dacryocystitis is, again, a severe case of dacryocystitis, preseptal cellulitis, internal hordeolums. This has been covered, I'm sure, to death at this point. So I am going to move on from the oral antibiotics. I know you guys have had an in-depth coverage of that from Blair earlier this morning. So our second case is a 74-year-old female. And this was a case that I saw a few years back. Wasn't as far back as the one from 14, 15 years ago of our first case. But our second case is a 74-year-old female. And she came in with a red eye. She came in with a light sensitive red eye for the last couple of days. She's just very kind of sore, kind of tender. This wasn't a lid case like the last one. This is because she had a red eye. She comes in for a red eye, which you guys know can be from a lot of things. So light sensitive, red, achy, sore. And she said, Doc, again, 74-year-old female, just kind of aches in this area. It just kind of hurts in this area, Doc. I'm sore, I'm light sensitive, and I'm just kind of tender in that area. She actually did this. She just kind of hurts in this area, Doc. Again, the lid wasn't swollen or anything like that. She's got a headache over her left eye for the last 2 or 3 days. Again, a week ago, I was fine. A week ago, there was no issues. The right side, there was no issues. I've never really had anything like this happen before. This is the first time. I wore contact lenses back in the day. Long ago, I haven't worn contact lenses in years, in decades. So way back again, she wore contact lenses, but this is not an acute contact lens thing, but just kind of sore in this area. I've got a red, achy, light-sensitive left eye. Again, been going on for about 2 to 3 days. A week ago, I had no issues whatsoever, doc. So take a look. You do your slit lamp exam. She's got 2+ diffuse injection. She has this irregular pattern on the cornea, this irregular kind of branching pattern on the cornea, and had 1 to 2+ cells in the anterior chamber. So remember that. Remember, she's got a mild anterior chamber reaction. It wasn't severe. She didn't have a plasmoid aqueous. There was no hypopion on the bottom. There was no fibrin in the anterior chamber. I mean, the cells were still cycling up against the warm iris and down against the cooler cornea. You know, that convection current in the anterior chamber, it was still doing this. But she did have some cells in the anterior chamber. So let's take a look here. This is her cornea. And I'll give you a couple of seconds, kind of watch this video. 74-year-old female, achy, sore, light sensitive left eye. She was 20/60. 20/60 in this left eye. Ignore the 2 red beams. Those are the aiming beams on our YAG laser. We laser anything in Oklahoma, even corneas. We'll just zap them right off the YAG laser. I'm kidding, obviously. Complete joke. At the time, our camera system was on our YAG laser, as our students and residents here in Oklahoma are doing YAG capsulotomies and SLTs. We have a camera on the laser so we can see what they're doing. But you can see this irregular kind of branching dendritic pattern, kind of dendritic-like pattern. 74-year-old female. Look at the haze. Again, she was 20/60. 20/60 in this left eye, 20/30 in the uninvolved right eye. So I'd ask you, is there anything that you'd want to put in the cornea, on the cornea, I should say, to help you evaluate this 74-year-old female that's had a red, achy, sore? Let's get some interaction here via the chat box. Anybody? Let's see if we can do anything via the chat box here. I don't know if we can or not. We might not. Let's see.
Do you want me to moderate that for you?
Sure, I can via the chat box, and I can look at it as well. Yeah, let's put anything via the chat box that you would want to put in this cornea, on the cornea, to help you evaluate. Let's get some interaction here. I got fluorescein, lissamine, rose bengal, some corneal sensitivity, which I think certainly would play a role this way. Yeah, let's put some staining. Absolutely. Let's put some sodium fluorescein in. I agree completely. So there is some rose bengal. You have some fluorescein, rose bengal, corneal sensitivity. I think that's all good on that. And here's the video. Here's the video. Pay attention to the video. We got some rose bengal in here. This irregular kind of branching pattern here. Irregular branching pattern. Just take a look at that staining. It's important to take a look at the staining. Is it really uptaking much staining here? I know you don't have depth perception behind the slit lamp. I will tell you, this was so acute. Corneal sensitivity was still normal at this point, although I think it's a very appropriate test. Anything else that you've seen the stain? I've told you the corneal sensitivity was normal at this point. Anything else that you guys would want to do at this point? All right. So based on the clinical presentation and the corneal appearance, what is your diagnosis? The polling is open. Polling, we got herpes simplex, dendritic keratitis, herpes zoster, pseudodendrites, whorl keratopathy, filamentary keratopathy, EKC, or a Pseudomonas bacterial ulcer. No wrong answers. The only wrong answer is a no answer on this one. Again, have some fun with this. I just want to reiterate the polling. This is not required. You will still get your credit even if you don't respond, but it's nice to kind of see what the group is thinking. Again, you guys can continue to answer here. Continue to answer in this 74-year-old female. Again, remember, this has been going on for 2 to 3 days. She's 20/60 in this eye, kind of achy, sore, light sensitive. That was the cornea. You guys saw the picture of the cornea. We watched this video. We put some stain in. And again, we've had about 70 of you respond. I love it. Completely anonymous. Let's see what you guys are thinking. 74-year-old female. Love the answers. Sharp, sharp group. It's usually in this prescribing orals lecture. It's probably not going to be oral keratopathy, is it? This is a prescribing orals lecture. EKC, it's not that as well. Filamentary, probably not that. I love the, 95% of you think this is herpes simplex or herpes zoster. Basically, 2/3 think it's herpes zoster, and about 1/3 think it's herpes simplex. I love the answers. I know you guys have been extremely well educated this weekend on things like that. So there we go. Differential diagnosis. I love the fact that these are our top two. These are always the top two. And I will tell you, usually the number one answer, I know you guys have talked about this a lot over yesterday and today with Jim and Blair. Usually the number one answer is herpes simplex dendritic keratitis. And I totally understand why when you take a look back here and you go, well, that certainly looks like a dendrite there. It looks like it's branching and irregular. But even though it looks like a dendrite, it also could be a what? It could be a pseudodendrite. But I love the fact that herpes simplex is one of our top two answers. If you practice long enough, herpes simplex will become our nemesis at some point in time. It will be I call it the nemesis. I tell our students and residents, it is your nemesis because it can present in so many different ways. It can present like a dendrite. It can present like geographic ulcer. It can present like a peripheral infiltrate. It can just have a haze and neovascularization. If it's stromal involvement, it just becomes our nemesis because it can present in so many different ways. There have been times that I thought it was herpes simplex, and it turned out not to be. There have been other times where I didn't think there was any chance this was herpes simplex, and sure enough, gall darn it, it turned out to be herpes simplex keratitis. I had a case about 10 years ago, and I'll never forget this 30-year-old male. He walks into our clinic, our acute care walk-in clinic at our Cherokee Nation Hospital, and he walked in with a hand over his right eye, and he walked down the hall. He was moaning as he walked down to the exam room. He's going, oh, I'm like, you wuss. Of course you're a male, but he's in 10 out of 10 pain. We get him back there. He's in 10 out of 10 pain. And this has been going on for a few days now. And we take a look in this 30-year-old gentleman. Again, not this case, but this 30-year-old gentleman. And he's got a 1 millimeter by 1 millimeter peripheral corneal infiltrate right next to the limbus. So I'm going to ask you again via the chat box, in your practice, what is the number one cause via the chat box? Tell me in the chat box, what's the number one cause of a peripheral corneal infiltrate in your practice? Okay. Number one cause of a peripheral, don't overthink this one. Tomorrow, if you have a peripheral corneal infiltrate, and there's the answer, contact lens wear, you got it. Staph would be number two. I agree. Those are your top two answers. Are a contact lens related use and abuse, contact lens overwear. They're sleeping in their lenses. They are overwearing their lenses. They're abusing their lenses. Contact lenses, number one. Well, this 30-year-old male that's moaning down the hallway to the exam room has never worn a contact lens in his life. He's not a contact lens wearer. So it's not that. So what's your number two? And you guys nailed it. It's staph. Staph blepharitis, lid margin disease is going to be your number two. Well, we took a look at this 30-year-old gentleman, and he's got grade 3 anterior blepharitis, grades 3 staph blepharitis caked all over his lashes, all over his lids and lashes. So I told our students and residents, we've got a hypersensitivity reaction here. We've got a case of marginal keratitis, a peripheral corneal infiltrate hypersensitivity reaction, secondary to this lid margin disease, secondary to staph bleph. And how would you treat that case? If you saw a patient with grade 3 blepharitis all over their lashes and a peripheral corneal infiltrate, again, via the chat box, let's have a little interaction here. If that was your patient tomorrow, grade 3 staph blepharitis with a peripheral corneal infiltrate, what would your treatment of choice be? It's not going to be an oral antibiotic. I know we're talking about orals here. Your treatment of choice would be what? And I would agree with Dawn there. It would be a steroid. Yep. And we might throw an antibiotic in there as well. A combination agent. Is that peripheral infiltrate infectious? Likely not. The central ulcer is lid hygiene, absolutely as well. Lid hygiene and a combination agent. That's how I treated that 30-year-old gentleman that was moaning down to the exam room. I told our students and residents, we're going to do some lid hygiene. We're going to put them on your favorite drop and my favorite drop. Tobradex or Maxitrol. That stuff will grow back a limb, right? It'll grow back a limb, that Tobradex. It's got the antibiotic in there to make you and I feel better, that we've got some coverage there, some protection there. But you know, and Don, as Don said, the main reason that you are using that Maxitrol or that Tobradex is for the Dex. It's for the steroid. So I put this patient on Tobradex. I put them on lid hygiene, and I said, we'll see you back in a few days. This is going to cure that pain, that redness, et cetera, et cetera. But I tell every patient with a red eye, one of three things. If one of three things happens, Mr. Jones, Mrs. Jones, if you have increased redness, increased pain, or a drop in vision, if any of those get worse, if your eye gets more red, if your eye gets more painful, or your vision starts to decrease, you need to come back sooner. And I told this patient, this is going to heal it up. Use your lid scrubs and use the drop here. And the combination of the steroid and the antibiotic are going to help and going to resolve this. It should be getting better and better and better every single day. We'll see you back in 4 or 5 days for follow-up. And he came back the next day or the day after that. Can't remember which one, but he came back sooner than the intended follow-up. He walked in, and I remember I'm like, uh-oh, he's back. And I walk in the room. He goes, Doc, I've got all three. And I said, what? What do you mean? He goes, you told me three things: increased redness, increased pain, and a drop in vision. My eye is more red, more painful, and my vision is worse than when I saw you the other day. Nice job. You were on your A game, weren't you, the other day? You put me on a drop and it made everything worse. And he got, oh, sorry about that, And I took a look, and that 1 millimeter by 1 millimeter peripheral corneal infiltrate now had a dendrite growing over the top of that. That was a case of herpes simplex marginal keratitis. I've seen 2 of them in my entire career. It's one of the 6 or 7 ways that herpes simplex can present in the cornea. We usually think the dendrite. That ultimately is what clued me in, is when I saw a dendrite, but herpes simplex can present in other ways. It can present as a geographic ulcer. It can present as a peripheral corneal infiltrate, even though that's very, very, very rare. And you guys know that contact lens abuse and staph are your top 2. This was a case of herpes simplex marginal keratitis. So I did the steroid diagnostic test in this particular case, and I've probably done it more than anybody else, and I don't advocate it. I'm not recommending that, but I did the steroid diagnostic test, and once I made it worse and the dendrite appeared, then we got him on the right treatment. And that case really just showed that if you practice long enough, herpes simplex is going to be your nemesis. It's just going to trick you up. It's tricked me up numerous times. So I love the fact, going back a slide, I love the fact that 30% of you, that it's our number 2 differential, roughly a third of you, herpes simplex, but 2/3 of you put herpes zoster. And I would ask you via the chat box, 2/3 of you put herpes zoster ophthalmicus. Why did you put herpes zoster ophthalmicus? Share via the chat box. If you answered, if you were one of the 2/3 that put herpes zoster ophthalmicus, why did you put that answer? Let's see here. Let's let these answers come in. I'm going to take a sip of water here. And we've got age, pain, facial pain. Because the rose Bengal, the staining, or I would say minimal staining, age, pain, body pain, plaque-like, no ulceration. You got it. You guys have nailed all of the reasons here. Herpes zoster ophthalmicus. If this was in fact herpes zoster ophthalmicus, shouldn't she have the rash? Shouldn't she have the vesicles? She's got globe involvement. You can see the globe involvement. Her eye's red. She's got injection. She's got a mild anterior chamber reaction. She's got corneal involvement here. Why doesn't she have the rash? Shouldn't she have the rash? And the answer is about 90+% of the time, the answer is yes. Usually the rash appears before globe involvement, but it's not in 100% of cases. The vast majority, and it makes the diagnosis easy, doesn't it? When they come in with facial pain and the rash respecting the midline, respecting the dermatome, which is the vast majority of cases, it makes it much easier. But there's a small percentage of cases, up to 10% of the time, it can present here before it presents here. So the answer is kind of a not yet. Why doesn't she have a rash in this particular case? I think it's a not yet type of case. She just doesn't have it yet. and not all cases develop it. Again, going back to the trigeminal, as Valerie indicated here. So not yet. It can present here before it presents here. And that facial pain, she said, it just hurts in this area. Remember that? She just kind of hurts right here, doc. He's almost telling you it respects the dermatoma, it respects the midline. I've got pain in this area. Now, when you have a patient that says, I've got facial pain, or I've got, frontal pain, temporal pain, when they've got pain in this area, what pops into your mind? There's a couple of diagnoses that pops in your mind via the chat box. What pops into your mind if somebody says it hurts in this area? And Kayla absolutely nailed it, is giant cell arteritis. You can't miss giant cell arteritis, temporal arteritis, cranial arteritis. It is something that we cannot miss whatsoever. So when I hear of pain in this area, I think of giant cell arteritis, temporal arteritis. But so maybe she's got that. What things do patients with giant cell arteritis or shingles, as Kim said, those are my top two, but I'm definitely going to make sure that we don't have giant cell arteritis, temporal arteritis, cranial arteritis. What other symptoms do patients with temporal arteritis usually have? And via the chat box, again, let's interact a little bit again. And it's the pain on chewing. It's the jaw claudication. It's the scalp tenderness, new type of headache. Yeah, that ischemia to the masseter mouth. That's why they have jaw claudication, malaise. Yeah, I love what Anthony put there. The jaw, and Hannah summarized all of them there. Weight loss, fatigue. I love that. I was very fortunate to spend 4 months with a neuro-ophthalmologist during my 4th year of training. You may know the name Leo Scorn. Leo Scorn is an OD and a DO. He's an optometrist and a neuro-ophthalmologist. He works at the Mayo Health System in Minnesota. And because he was the only neuro-ophthalmologist in about a 60 to 90 mile radius, everything neuro filtered to him. We saw giant cell arteritis about every other week in when I was spent the 4 months with him. Can you imagine that if you're seeing a case of giant cell arteritis every other week? Well, he was the only one in a 60 to 90 mile radius, so everything filtered to him. And it was amazing to see the malaise, the weight loss, the fatigue. We had one patient that said, I felt like I haven't had the energy to get out of bed for the last 3 weeks. So, Jennifer and all of them are so right. Hannah, the jaw pain, the fatigue, the scalp tenderness, the occipital headache, all of these can be the weight loss, the malaise, the loss of appetite. I haven't had energy. I haven't had, this loss of appetite for a long time. So you need to ask those questions because you cannot miss giant cell arteritis, almost always in people in their 50s, but more likely 60s, 70s, 80s, and 90s, older patients. You never say never in medicine, but GCA is almost never seen in somebody under the age of 50. So look for this in your 60s, 70s, 80s, 90-year-old patients. And again, when she did it hurts in this area, I asked her. She had no lack of appetite or loss of appetite, no malaise, no fatigue, and no hip pain. She had no jaw claudication. So I felt pretty comfortable that this wasn't giant cell arteritis, that it wasn't cranial arteritis at this point in time. Could I have sent her for a SED rate to see reactive protein? Absolutely, I could have sent her that. But I felt pretty comfortable that this was not giant cell arteritis. Again, then I'm going to fall back to the second most common cause, or I should say other cause of pain in this area, and that is herpes zoster ophthalmicus, as you guys said. Should she have the RAS? Yes. In 90+% of cases, she doesn't. In this point, as we said, I think it's kind of a not yet scenario. And you go back to what the cornea looked like. This certainly looks like a dendrite, but it also could be a what? A pseudodendrite. And that leads to, how do you differentiate a true dendrite from a pseudodendrite? How do you differentiate? I'm going to open that up to you guys via the chat box. How do you differentiate? A true dendrite has two things that a pseudodendrite does not. A true dendrite has, as Hannah just said, number one, terminal end bulbs. A true dendrite has terminal end bulbs, and a true dendrite is often ulcerated. There is positive fluorescein staining. There is ulceration. A true dendrite is going to stain more, and a true dendrite is going to have terminal end bulbs. I bet this has been covered already this weekend as well. When you take a look at this lesion, in this case, with a 74-year-old female, I know you guys don't have depth. You're not behind the slit lamp. There is minimal to no staining here. There is minimal staining, and this lesion is heaped up. It is elevated. It is not ulcerated. There's no ulceration. There's minimal staining here. The age, the facial pain, the doing this, and the way that this appeared, this is a pseudodendrite in herpes zoster ophthalmicus. So I completely agree with the 2/3 of you that put herpes zoster. Why did I think that? Because of the age, because of the pain, and because of the corneal appearance that we just went through, herpes zoster ophthalmicus. How did I treat this case? With an oral antiviral. An oral antiviral, valacyclovir, 1,000 milligrams 3 times a day for 10 days because she's over the age of 65. My rule of thumb is people that are over the age of 65, I give them 10 days of an oral antiviral. If they're under the age of 65, I will give them 7 days. That's based on some literature from Amrod, among others. There's no like hugely strong literature, but there is some literature out there. Over 65, 10 days, under 65, 7 days. She was over 65, so I gave her 10 days of oral valacyclovir. I gave her a steroid and a cycloplegic. This is back in the days when we could get some hematropine. And so again, don't forget about that grade 1 to 2 plus cell and flare. Do you put a dendrite on a steroid? And the answer is no. Unless you have trouble and need help with diagnosis, I would not put them on a steroid. But a pseudodendrite is completely different. Instead of an infectious entity like herpes simplex, and that dendrite is the virus eating through the cornea. That's why there's ulceration, terminal end bulbs, et cetera, and you need an antiviral like Zergan or an oral antiviral. With this, yeah, we're going to have an oral to shut down the systemic virus, the shingles virus, varicella zoster virus, but this is a largely inflammatory component, and I would recommend you treat your pseudodendrites with a steroid and a cycloplegic. Helps with the pain. In this case, it was a no-brainer because of the anterior chamber reaction. We've got the pseudodendrite as well. So again, I treated her with an oral antiviral, a steroid. That was our differential. That was our diagnosis. And the treatment was an oral antiviral, a steroid, hematropine, or your cycloplegic, whatever you can get access to, along with you could add some artificial tears in as needed as well. So that was our diagnosis and treatment with our 74-year-old female, a case of shingles, an atypical case of shingles that presented here before here. So let's talk on herpes zoster ophthalmicus. Nearly 1 million Americans develop shingles every year. And you may say, yeah, that's true, but we've got these vaccines now. We've got the Shingrix vaccine, which is now the main one used. Back before that, we had the Zostavax vaccine, and it's cut the incidence of shingles. And we should be seeing this less and less and less and less. And in reality, we're probably seeing this more and more and more. And why is that? Why are we seeing, why? And you can type this in via the chat box, not via this here, but why do you think the incidence of shingles is rising? I want to hear via you guys, via the chat box. Do you think the incidence of shingles is going up? And if so, why? Via the chat box. Anybody have any theories on that? Let's see here. People living longer, baby boomers are aging, poorer immune systems, COVID. We can blame COVID for everything, can't we? It's absolutely rising. I 100% agree with Susan there. It should be going down. We've got these great vaccines that are cutting the risk of shingles. Is it the age? Is it people aren't getting vaccinated? I think there's a lot of different reasons, vaccines. Age, absolutely. Our boomers are into their 60s and into their 70s. And so that's going to play a role. So aging is going to play a role. Lowered immune system. Most people vaccinated, people with the virus don't maintain their immunity through small amounts of viral particles in the air like they used to. Again, there's a lot. You can see it. Less chicken pox exposure. I think that's an interesting one. It's definitely age, the boomers, lowered immune systems, etc. Stress is Pamela nailed it. Stress. No, we're not a stressed out society, are we? Stress plays a role. We're all kind of connected in each other's business, the internet, all the stuff that goes on in our world. Stress is playing a role. But I wonder if it's that, as multiple people have commented, are less people getting chickenpox. My kids are 11 and 8, and they're vaccinated for chickenpox. They're not going to develop chickenpox like I did in the 5th grade. I got chickenpox in the 5th grade. I remember it, getting chickenpox in the 5th grade. And when I had chickenpox, and when children, as the general population, as a society, when kids are getting chickenpox, that's exposure for the virus for my parents. Maybe I was around my grandparents and aunts and uncles and, people, there's more exposure. And does that provide them a little immune booster? I think that's an interesting theory. I wouldn't fight you a whole lot on that theory. I think I probably agree with that theory. And there's other theories out there as well, but it's a combination of all of that. And as somebody said, shingles is absolutely going up. Where's the number one place people get shingles? It's the torso, abdomen, back area. That's number one. Herpes zoster ophthalmicus is up there as well, probably number 2 or number 3, but you can get shingles anywhere. My grandfather is 96 years old, still on the farm in Flasher, North Dakota. 96 years old. And about 5 or 6 years ago, he got herpes zoster. He got shingles on his left butt cheek. And he was miserable, absolutely miserable. He couldn't sit for like a week, had to lay on his right side. So you can develop it anywhere. But the torso, kind of abdomen, back area is likely the most common location there. So let's talk about the varicella zoster virus. Again, most of us got this in childhood. We got chickenpox, the primary infection, highly contagious. How many of you had chickenpox parties growing up? I know I did. When somebody in the neighborhood, when their 8, 9, 10, 11, 12-year-old got chickenpox, bring the neighbor boy over that hasn't got chickenpox. He needs to get chickenpox when he's 11, so you don't get it later in life when it tends to be more severe. So highly contagious, that itchy rash. You guys all know what chickenpox is. Again, the initial presentation, the primary infection for the varicella zoster virus. Again, there's now a vaccine that's available. My kids likely will not get chickenpox because of this vaccine. So again, does that help the kids? Maybe, probably. Does that worsen shingles? Could play a role in that as well. And then this goes dormant and this reactivates. And when does this reactivate? When we are what? Stressed, when we're stressed, when our immune system is lowered, et cetera, and it reactivates as shingles. And we talked about where the most common presentations of shingles are. Again, torso, abdomen, back. And generally speaking, who gets shingles? People in their 70s, 80s, and 90s. Why did my grandfather get shingles? Because he was 90 or 91 years old, and he's 96 now. He got this at 90 and 91 years old. Why did he get it? Because he was 90 years old. This is a disease of only people in their 80s and 90s, right? Wrong. And again, I'm sure somebody's already mentioned this. I usually, when I'm live, I have people raise their hand, and I want it via the chat box. So I usually have people raise their hand going, how many of you have seen a case of herpes zoster ophthalmicus? Raise your hand. Okay. In their 60s. All right. Keep your hands up. 50s. Keep your 40s. And I just keep going down, and hands go down, but there's still hands going up. I would be curious via the chat box. What is the youngest patient that you have seen with shingles? Via the chat box, the youngest patient that you have seen with shingles. Anybody want to type it in the chat, or just type the decade? Look at that. Youngest patient that you've seen with shingles. And look at all of you're not seeing a whole lot of 96, 91. Look at that. And there's some, but the vast majority, 9 years old. Holy smokes. Yeah. And it's just look at all those answers of patients in their, it's not 70s, 80s. Yeah, they can develop that. My grandfather did, but it's in their 60s, in their 50s, in their 40s, in their 30s. It's getting younger and younger and younger. And it's interesting. It's 36-year-old who is on anabolic steroids with that. Again, it's getting younger and younger and younger. So if you see a patient that gets herpes zoster ophthalmicus and they're 87 years old, why did they get it? Because they're 87 years old, very likely. But if you see a patient that's 37 years old, they're 50 years younger, is there anything that you need to be worried about? And the answer is largely no. Most of those cases in people in their 20s, 30s, 40s, and 50s is still stress related. The literature seems to indicate about 80+% of those cases are still just stress related. It's stress, it's lowered immune system, and you treat it and it's likely going to go away with no huge long-term morbidity and mortality for the vast majority of the patients. But that's not all of them. 80+% is not 100%. And for that reason, I think it's sound medicine to communicate with their doctor, their PCP, and says, hey, we've got a mutual patient here, 37-year-old, that I'm managing their herpes zoster ophthalmicus. So they got shingles in my neck of the woods, the area that I treat, but I just wanted you to make you aware of it. It brings me back to a case that I saw with Leo Scorn about 15 years ago. And it was the sister of one of our technicians. She was 41 years old. And she had one of the nastiest cases of herpes zoster ophthalmicus that I'd ever seen. I mean, just a severe rash, just perfectly respecting the dermatome, respecting the midline. And she was 41 years old. And I remember talking with Leo and talking with some of the other doctors, should we send her for a systemic workup? Should we send her, for things like chest x-rays? And should we send her for HIV testing and a bunch of blood work and all this good stuff? And I remember we were debating back and forth, and we decided, yeah, we should probably do that because she's fairly young. She's 41 years old. And all of the testing that I just mentioned came back normal. It was all normal. And I felt bad that we'd waste her time and money, insurance, all this stuff. And it all came back normal. It just turned out to be stress is what we thought. And I felt bad about it until my last day at that rotation. And I'll never forget, our technician came in crying and said, my sister was just diagnosed with breast cancer. And it makes you wonder, was there a link? And I don't ultimately know whether it was the breast cancer that played a role. Maybe it was just coincidence. But she was just diagnosed with breast cancer. And for that reason, my general rule of thumb is anybody that's about 40 years old or younger, I'm going to at least communicate with their PCP. Maybe it's 50 or younger, somewhere in there. Again, if it's 87, it's likely stress related. But somebody that's in their 40s or 30s or younger, I'm going to at least communicate with their doctor and say, we've got a mutual patient here that's got herpes zoster ophthalmicus, and I just wanted to let you know. And you know what they're likely going to say? So that's what the PCP is like. And so they're seeing this more and more common in people in their 40s and 30s and 20s as well. They're like going to go, and they're probably not going to recommend a systemic workup, but I think it's sound medicine to at least have that conversation. And I'd be curious, those of you that mentioned the younger patients, was it stress related, or was there anything at cause of this? Was it cancer? Was it HIV or AIDS or anything like that? Likely it's not going to be, but it could be. It's likely not, but it could be. Anybody in the chat box, if it probably was stress, put stress, or was it something else? I'd be curious on that if it was stress or something else. No childhood vaccines, that certainly could play. HIV probably is just still stress. Probably is. But my rule of thumb is if they're in their 40s or younger, autoimmune disease, if 40s or younger, I tend to get there, just let's get some blood work. Let's just take a look. Stress, undiagnosed type 2 diabetes, stress. There's a lot of different causes, but communicate with death of a relative. Again, most of the time it's stress, but it could be something else. And for that reason, I recommend a systemic workup if they're in 40s or 30s, or at least have a conversation with their doctor. You guys are familiar with the symptoms, the headache, the malaise, the tingling, et cetera, and you guys know what Hutchinson sign is. A rash on the tip of the nose, side of the nose, really rash anywhere on the nose. And it signifies that the globe is more likely involved. The globe is much more likely to become involved if the nose is involved. It's about an 80% chance based on the literature there. Signifies involvement of the external nasal nerve. And if that's involved, the nasociliary nerve is likely involved. And you want to really look closely for corneal involvement, conj involvement, anterior chamber involvement as well. Hutchinson sign is pointing you that really watch that globe closely. Watch it classically. And again, there's a lot of things that can be involved. I don't have time to go through this. I'm guessing this has been covered already. The answer to the question of what can herpes zoster cause in the eyeball, the answer is pretty much anything that ends in itis. Anything that ends in itis, whether it's conjunctivitis, keratitis, uveitis, iritis, retinitis, choroiditis, optic neuritis, anything that ends in itis in the eye, herpes zoster can likely cause. Yes, the rash, respecting the midline, respecting the dermatome is most common, but it can cause a lot of things. And maybe anterior uveitis is one of the most common, if not the most common, globe involvement. So pay attention, look for that anterior chamber reaction. I don't have time to go through the anterior chamber stuff and uveitis stuff, but it can cause a lot of things when it comes to herpes zoster ophthalmicus. Okay, I want to ask this question. What is your medication of choice? Somebody put in, they had a case of a young patient, breast cancer, and it was stage 3 a year later. Absolutely. And again, most likely it's stress, death of a relative, something's going on in their life. Maybe it's a divorce, something like that. But it can be other things. So, what is your medication of choice when treating herpes zoster ophthalmicus? Let's say you've got a standard patient, typical patient, standard patient. They don't have the pseudodendrite. They came in and doc, it hurts. Got some tingling. I've got some pain, right? They got facial pain, no jaw claudication, nothing like that. And you diagnose a classic case of HZO. What would you put them on? Acyclovir, valacyclovir, famciclovir with the appropriate dosages, or Zergan? What do you think? What's your medication of choice when treating herpes zoster ophthalmicus? We are polling the audience. Again, this is optional, and you got it. See, there's multiple correct answers here. I would say the correct answers are B, D, and F. B, D, and F. Remember, if you know the dose of herpes simplex, you double it to get to herpes zoster. If you know it for herpes zoster, you have it to get to herpes simplex. So A, C, and E are the herpes simplex milligrams. Acyclovir, 400 milligrams daily. Valacyclovir, 500 milligrams daily. Famciclovir, 250 milligrams daily. A, C, and E are the herpes simplex. B, D, and F are your herpes zoster. You double the milligrams 5 times a day for acyclovir, 3 times a day for valacyclovir, and famciclovir. So let's talk on oral antivirals. In our last 8 minutes, your oral antivirals. And, these are obviously important medications for herpes simplex, for herpes zoster. Your oral antivirals are so key. And what I like about these is your risk reward is so in your favor for most of these cases. Your oral antivirals, they are very, very safe systemic medications. Yes, you may have a zebra, a rare worry here and there from some patients, but the vast majority of patients, I take a quote from Dr. Nolan, a good friend of mine. He's a PCP here locally in Tahlequah for Cherokee Nation. And he says, unless they're on dialysis for the 7 to 10 days, Nate, that you're going to prescribe this for a case of herpes zoster ophthalmicus, you are likely good for the vast, vast, vast majority of cases with herpes zoster ophthalmicus. Yeah, if they have dialysis, then maybe we have to dial it back and work with their PCP on that. And I'll show you a table here in just a second. But for the vast majority of cases, the reward is up here and the risk is way down here. These are very safe, tolerable medications for the vast majority of patients. So the key is the window. 72 hours within symptoms. A guy way back named Herb Kaufman said, well, you want to get these patients within 72 hours of symptoms. That is mostly true based on the literature. The earlier yet you can get them on therapy, the better for these patients. So I want to get them ideally within 72 hours if possible, especially for acyclovir. So there's your 3 main medications: acyclovir, valacyclovir, famciclovir. And you can see the dosages: 800 milligrams 5 times a day for 7 to 10 days, acyclovir 1,000 milligrams 3 times a day for 7 to 10 days, and famciclovir 500 milligrams 3 times a day for 7 to 10 days. I already covered the kind of 7 to 10 days. Why 7 to 10 days? My general rule of thumb, just based on a couple of studies, is patients that are above the age of 65, I like 10 days. Patients that are below the age of 65, I like 7 days. So that's kind of how I differentiate based on that. Acyclovir has been the historic standard. Why is acyclovir the historic standard? Because it was generic first, cost, cheapest, etc., etc. But your number one, going back to this, is a clear winner of 59% of you are doing valacyclovir 1,000 milligrams 3 times a day. The number 2 answer is acyclovir 800 milligrams. So your guys' is clear number one, 4 times more common than the next most common answer is valacyclovir 1,000 milligrams 3 times a day. Why is that? Because it's been generic for a long time. The cost differential between that and acyclovir is much closer, better insurance coverage. There's really about 4 reasons why I like valacyclovir better than acyclovir. Valacyclovir and famciclovir better than acyclovir. So if you're taking notes, you want to remember this. These are the 4 reasons why I prefer valacyclovir and famciclovir over acyclovir. Number 1 is obvious. Number 1, what's the obvious one? Better dosing schedule. I would rather take a pill 3 times a day compared to 5 times a day. So better dosing schedule. That's going to be number one. Number two is their prodrugs. The body converts these to acyclovir in the body. They utilize them a little bit better. They have a little bit better bioavailability, 25 to 80% more bioavailable, depending on the study that you look at. So the body utilizes these a little bit better. That's why they're only needed 3 times a day compared to 5 times a day. So number one's a better dosing schedule. Number two is they're more bioavailable for the body. Number 3 and 4 are very clinical. 3 and 4 are very clinical reasons. Number 3, remember that 72-hour window? If you ever have a patient that comes in on a Friday and says, I'll tell you, the tingling and the pain kind of started on Monday, but it's harvest season, doc. I'm a farmer. I had to be on the combine. I just grinned and bared it. I just got through it and I could finally get in today. They came in on a Friday and this started on Monday. They are outside the 72-hour window. They're beyond that 72 hours, that 3 days. They're like at 96 hours or 4 days. If you ever have a patient that presents outside the 72-hour window, the literature really guides us that valacyclovir and famciclovir are better outside the 72-hour window. So that's number 3, better outside the 72-hour window. And number 4 is maybe a lower incidence of post-herpetic neuralgia. The presence of pain 1 month after the rash has subsided. That is the definition of post-herpetic neuralgia. I don't think I'm gonna have time to get to that slides there. I'll get to all this in just a second. But post-herpetic neuralgia, there are some studies out there by Omrod that indicate about a 30 to 40% lower incidence of post-herpetic neuralgia with valacyclovir and famciclovir compared to acyclovir. So for those 4 reasons, better dosing schedule, better dosing schedule, more bioavailable, better outside the 72-hour window, and a lower incidence of post-herpetic neuralgia. That's why I lean to valacyclovir. That's why you guys lean to valacyclovir as well. So that's what I use. It's what we have on formulary. Again, these are all correct options. They are again, really the only main contraindication is kidney disease. Yes, there are rare cases, with elderly patients that can cause visual hallucinations and things like that. That's out in the literature. I've never had a patient report that. So it is pretty rare. The main contraindication is going to be kidney disease. In my last 2 minutes before we pause for questions is your lactose, so just some kind of miscellaneous stuff. If you have a lactose intolerant patient, okay, here's a couple of recommendations for the lactose intolerant patient. We lean more towards the valacyclovir. There are specific preparations of acyclovir that are lactose free, but you can't guarantee that. So valacyclovir and the brand name Valtrex are recommended if you ever have a lactose intolerant patient. So there you go for that. Pediatric patients, you're prescribing the 9-year-old that had shingles. Somebody mentioned the 9-year-old that had shingles. When can you prescribe that? Acyclovir and valacyclovir are indicated. They've been studied. Anybody over the age of 2 for valacyclovir, down to neonates for acyclovir. Famciclovir, it's 18 and above based on the literature and the studies there. Childbearing, again, these are back in the days of pregnancy categories. These are safe for pregnancy if you need to go to that. Hopefully you don't, but if you need to do it in women in childbearing age. There's your kind of renal dosing, adjusting based on kidneys. And again, I go back to people that are much smarter about the kidneys than me when it comes to that. If you're prescribing, you can adjust this really only if they're on dialysis. If they are not on dialysis, based on the recommendation of our PCPs, you are good for 7 to 10 days for our oral antivirals. They are going to do just fine for that. So that's how we do it. Pediatric dosing, somewhere in this range for your pediatric dosing for herpes simplex. I don't want to confuse that herpes zoster. Again, it could be unusual, but herpes simplex right there. So with that, I am out of time. It is 1:40. And I am going to pause here. We didn't have time to go into the vaccines, things like that. I'm sure somebody's covered the vaccines at this point. But Shingrix is your main vaccine. It's been around for, again, 5-6 years now. So no big surprises there. And your post-herpetic neuralgia, constant intermittent pain that persists for more than 1 month after the rash is healed. Age is your biggest thing, and there's a variety of ways that this can be treated. So with that, I'm going to pause here. We have reached our 100 minutes. Dr. Jen, I'm going to turn it over to you.
That was amazing. That was such a great presentation. And I'm sure I speak for everyone that your engagement and keeping everybody involved. It is hard as somebody who presents mostly virtual. It is really hard sometimes. I know you want to ask a question and like look for the show of hands or smiles. So thank you for involving everybody as we sit at our computers here. That was really great to hear everybody's answers and to keep us engaged. So thank you for that.
Yep.
And I'm scanning through. I mean, I think you actually answered a lot of the questions that were there. So as I go through, if you have any questions that Dr. Nate didn't answer, now's the time. Please put them in the chat or Q&A. We have a few minutes for that. There was actually one question that I know you didn't cover. I was trying to see if you cover all these. How long after a zoster infection do you recommend the Shingrix vaccine? I know we didn't get to the vaccines. We covered some of this yesterday, but how long do you usually wait?
Yeah, so our doctors are recommending as soon as it subsides, they typically recommend waiting 3 to 6 months after if you've got an active shingles infection, whether it's, up here or whether it's on the body, let that subside for 3 to 6 months. Once you've had it once, the chances of getting it again are not high. You can get it again. That there have been reactivations, but the recommendation is 3 to 6 months. That's the ultimate answer for how long we wait after that. The question right below that, are you using topical treatment with herpes simplex or just orals? So that's going to be depending on the availability. Yeah, in my system with Cherokee Nation, I am speaking against the literature here. I do both. So if I've got a patient with herpes simplex virus, again, not herpes zoster, but herpes simplex, I treat them with an oral and with Zergan. Now, I'm going against the literature on that. The literature says one or the other. So you don't need both, but I practice in a free system where medications are at no cost to the patient. They are available to the patient through our Cherokee Nation pharmacies. When I prescribe a medication, they don't go to Walmart or Walgreens or CVS. They get it actually at their own pharmacy. So it's available and it's free. So I've overcome, because of our system, the two biggest hurdles was Zergan, which is the cost and the availability. So the literature says one or the other. I use both because they're free. If you made me pick one, out in where medications are not free, I probably would lean towards an oral because Zergan's a little bit hard to get, and it can be costly versus the oral medication. So the literature says one or the other. So
thank you. This actually goes back to that. I have another question that just came in that goes back to that awesome first case that you presented.
Yeah.
Will the 30-year-old who had the MRSA eyelid abscess will she have MRSA her whole life or not because it was walled off and maybe didn't go systemic?
Yeah, so that's a good question. I don't know if we know that for certain on that. I believe that abscess came from somewhere. So in our chart, she would be labeled a MRSA carrier. There's precautions when you're having surgery. Sometimes that's the last patient of the day because you have special cleaning and things like that. So in our chart, we would label that patient as, yep, they've had MRSA. I would not omit it just because it was an abscess and it was walled off. That it had to come from somewhere. So it's been in her body, even the process of the removal, did it liberate anything like that? So I would label her as a MRSA her whole life because of that. And just make note, probably will never cause an issue, but I would just make note of that in her chart. So
thank you. Better safe than sorry.
better safe than sorry. I completely agree.
Would there be a consideration of a Medrol dose pack on HZO to reduce inflammation and risk of post-herpetic neuralgia?
So I certainly think you could consider that. It's not part of my standard protocol when patients come in. I will, however, if they don't go down the road that I want them to go down, if they don't follow the normal resolution, I will work with their doctor pretty quickly to consider putting them on a Medrol dose pack to reduce inflammation, like we said, and the risk of post-herpetic neuralgia. So I don't put them on that day one. But if we don't go down the normal resolution, if this is not getting better by day, 3, 4, 5, and we've still got significant pain in there, I will consider that in the first week, usually working with their PCP to get their thoughts on that. Another question was, what percentage of varicella zoster actually has ocular involvement? Boy, I'd have to look to have the number off the top of my head. I want to say that number, boy, I'd be guessing here. I want to say it's somewhere in the 20%, 20 to, it's not high. The majority of shingles does not present in our neck of the woods. It's not 50%. It's not 80%. The percentage of shingles that has like everywhere from head to, to toe, it's going to be a smaller percentage, 10 to 20%, 15 to 20%, somewhere there. But I'd have to look at that stat again to get the exact number. But that's what I have off the top of my head. If anybody else knows off the top of their head, please chime in via the chat box. I'd love to hear that for you. What's systemic workup for somebody under the age of 40 with herpes zoster ophthalmicus? I am going to get a complete blood workup. I want to get their complete blood work with differentials, looking for any types of blood cancers, things like that. May consider a chest X-ray as well. And really, I'm going to let their doctor dictate that. What I'm going to do is I'm going to recommend a standard blood panel. I'm not going to start sending them for MRIs of the breasts and the brain and things like that. But that's what I would consider. So